Welcome to KARAVALI PEDICON 2023 and Dr. Meera Baliga oration. IIP Udupi takes privilege along with Manipal Academy of Higher Education Manipal to welcome all the delegates gathered for our annual conference. So this is going to be a 2 days program. Till today evening we will have the scientific session followed by a banquet tonight, and tomorrow morning till 1 p.m. we will have the scientific session. Without further ado, we will straight away start with our scientific session. Over to our scientific committee for the further proceedings.
Very good afternoon to everyone. I am very pleased to see so many eminent faculty of the field present here. KARAVALI PEDICON, it provides a very unique opportunity to all of us. It has attracted delegates from all over the country. So without much ado, let us start the much awaited scientific session.
The first talk of the day is on genetic testing and counseling. We consider it a great honor to welcome Dr. Edwin Dias, Professor of Pediatrics, Srinivas University, and Dr. Sucheta Rao, Professor and Head of the Department of Pediatrics, KMC Mangalore, to chair the dais. We invite Dr. Tanya, Additional Professor at Amrita Institute of Medical Sciences, Kochi, to grace the occasion with her speech.
As the speaker is getting ready with the slides, I would want to introduce the speaker, Dr. Dhanya Yeshodaran. She is MD Pediatrics, KMC 2006, and she has 14 years experience in pediatrics, especially children with genetic disorders. She is presently the Additional Professor in Department of Pediatrics, Division of Pediatric Genetics at Amrita Institute of Medical Sciences, Kochi. And she has field of special interest is diagnosis and management of children with developmental delay dysmorphism and metabolic disorders, counseling and prenatal diagnosis for families with genetic disorders. Now, when we started my studies in St. John's, we had a very good genetic researcher. I don't know whether you know Dr. Manorama Thomas. No. She was one of the senior ICMR and all. So that day we wanted to do a very interesting study those days. And then she was very interested in guiding us. Of course, time flew so fast and we do not know. We have reached already the age where if you see the internet, there is so much of information. And this is the area which is the budding area. Even there is a DM, I think, in Sanjay Gandhi on the institute since the last 10, 20 years. So this field as clinical genetics has developed a lot, and even the genomic studies and everything now they usually do is we go to the pediatric neurologist, they want the study and for diagnosis. They want if you want a male Nunans, then again you need a study. So like that, so genetics has really taken over the whole field of pediatrics now. And to tell you that, you know, that Udupi has got IMR of 4. I was quite shocked. And Mangalore has got IMR of 5. So out of that 4, 5 is basically the genetics. So we are following the Western trend. And over to you, madam.
Okay. Good afternoon, everybody. At the outset, I'd like to extend my sincere thanks to all my teachers here, especially Sunil sir for inviting me to this alumni meet. And I'm extremely elated to stand in front of my own teachers and to deliver this talk. And it actually brings back all the memories of my old PG days at Manipal. So, I have been asked to cover a very vast topic actually, which I'll try to cover in the next 30 minutes of genetic testing and counseling, the whens, whats, and whom's. So this is I'll start my presentation with this cute little baby. From the face itself, it's very evident that this is a child with Down syndrome. So all of us during our UG days, or let me say the PG days, it would have been one of the first few genetic cases that we would have seen. And we would have been excited to make a diagnosis of Down syndrome. But during those days, all these diagnoses were just clinical diagnoses and nobody ventured to go and do a genetic test. But now time has changed so much that even for a subtle dysmorphism or a mild developmental delay, we try to find out some or the other genetic causes and try to label the child with a genetic disorder because that's the need of the time. So by the end of this talk, I hope I will be able to give you answers to these questions as to who needs genetic counseling, when will you suspect a genetic disorder, the types of genetic disorders that we come across, what is to be ordered for what, and whether autism, does it need a genetic testing or not. So who needs genetic testing? Any consanguineous couple, especially when there's a family history of genetic disorders, or when one among the couple is having a genetic disorder, or any couple having a child with mental retardation, dysmorphism, global developmental delay, or when there are multiple male members in the family with mental retardation, especially on the maternal side, always go ahead with the genetic testing and counseling. Then history of recurrent first trimester abortions in a lady, recurrence of similar anomalies in multiple pregnancies, unexplained deaths in the newborn period might be a metabolic cause, recurrent Down syndrome. So these are few among the vast list of the indications for a genetic counseling. Now, when will you suspect a genetic disorder? Especially in the newborn period, when already the antenatal scans in the baby have shown multiple anomalies, or when there is a prenatal onset of short stature, overgrowth, microcephaly, macrocephaly, dysmorphic features in the child, multiple anomalies involving multiple systems in a child, unexplained neurocognitive impairment where there has not been any history of birth asphyxia, family history suggestive of a hereditary disease, and again autism. Now, steps of evaluation. Now, this is nothing different from our normal pediatrics, but here we give more importance to a detailed family history, wherein we take a 3-generation family history, a detailed pedigree drawing, age and sex of the affected family members, age of onset of disease or when they died, their ethnic background and consanguinity, and in the history, special stress given to prenatal onset of any illness, drug exposure, infections, or radiation in the mother, perinatal history, that is any insult during the time of delivery, birth asphyxia, anthropometry, seizures or any complications in the neonatal period, any seizures, development delay, whether the development has been progressive or static in the childhood. These are all the history which you should be taking. And then in the clinical examination, give more importance to anthropometry, especially in cases of growth retardation, short stature, and detailed head to foot examination. Now, this is just a comic slide to just show you that anything and everything is dysmorphism. That is something which is different from normal is labeled dysmorphic. Being tall, being very short, being fat, being thin, having a tall head, a short forehead, everything is dysmorphism. So interestingly, dysmorphism as such has been divided into 4 different groups as malformations, deformations, disruptions, and dysplasias. So malformation is nothing but an intrinsic developmental defect like a neural tube defect or an atrial septal defect or a cleft lip or cleft palate. A deformation is actually distortion of a normally developed structure due to some mechanical forces like club foot or dislocation of hip, especially when there's an overcrowding with the uterus due to an oligamnios or fibroids in the mother, or breakdown of a normally developed or developing structure. That is due to a mechanical or a vascular insult like an amniotic band sequence, and a dysplasia, that is an abnormal cellular organization in the tissue That is, example is skeletal dysplasia. So the importance of classifying dysmorphism is that when these anomalies are present in single, that is when they are present in isolation, they are usually not associated with a genetic etiology. But when there are multiple malformations together, you should always suspect a genetic disorder. So at the end of your examination and your history taking, you now have come to a conclusion whether your problem is of prenatal onset, that is whether it was present in the intrauterine life, and whether it was a single defect or a multiple malformation syndrome, or whether it has come postnatally. So usually, as I've already told, single primary defects are usually not having any genetic origin except for dysplasias, and all other groups usually are associated with some or the other kind of chromosomal or single gene disorders. Now, before coming to the decision as to what test has to be done for what, we should be knowing about the basic structure of a DNA and a chromosome. So we know that the human body consists of 22 pairs of autosomes, and we have 2 sex chromosomes. And within the chromosomes, you have your DNA, you have the genes within them, and the genes contain exons and intronic regions. The exons are the coding regions, introns are the non-coding regions, and within them you have your bases. So you have a genetic disorder either when there is a problem at the chromosomal level where there is a deletion or a duplication in a chromosome, or at the level of the gene where you can have a mutation or you can have a deletion or a duplication of the exons. So the importance of knowing is that the test that you order always depends upon what type of disorder you are suspecting. So types of genetic disorders are broadly classified into a chromosomal disorder, a single gene disorder, and disorder of multifactorial inheritance. Again, in the chromosomal disorder, you can have either a deletion, a duplication, or you can have a mutation or an exonic deletion or a duplication, a triplet repeat disorder, and again you have disorders of multifactorial origin. They are diabetes, and other examples are psychiatric disorders. And among the single gene disorders, they are further divided depending on their inheritance as dominant, recessive, X-linked, Y-linked, and mitochondrial. Again, this classification is important only when you go for a counseling in the couple. Now, this is just a recap of what all of you know. We have autosomal dominant disorders where both sexes are affected, and there is 50% recurrence risk if the parents are affected. So, the child can get this disease if either of the parents are affected, or when both the parents are normal, the child can get the disease if the child has developed a de novo or a new mutation. So examples include achondroplasia, tuberous sclerosis, Marfan syndrome, myotonic dystrophy, etc. Then you have recessive disorders where usually the parents are unaffected. They are usually silent carriers of the disease, and they have usually a 25% recurrence risk in every pregnancy. Examples are congenital adrenal hyperplasia, SMA, mucopolysaccharidosis, etc. Now, autosomal recessive disorders are always very common when the couple marry consanguineously. So, if you look into the prevalence of consanguinity in India, you see that southern part of India has the higher rate of consanguinity when compared to other parts of India, especially the states of Tamil Nadu, Andhra, Karnataka, Maharashtra. They have a high level of consanguinity. That is between around 20 to 39% is the consanguinity in these states. So, the importance of consanguinity is that the greater your degree of consanguinity, the number of genes that you share is more. So, if it is an uncle-niece marriage, which you call as a second degree consanguinity, the number of genes they share is 1 in 4. And when it comes to a first cousin marriage, it is 1 in 8. And when it is second cousins, it is 1 in 32. So, that is why the chances of sharing a defective gene by a couple who is married consanguineously is very high. Then you have X-linked disorders. We all have studied from our UG times. We know DMD, hemophilia, these are all X-linked disorders. Here, only the males will manifest the disease, the females will be usually silent carriers. And an affected male will never transmit the disease to his children, but an affected female can transmit the disease to 50% of her male children. So importance of X-linked disorders is that whenever you make a diagnosis of X-linked disorder, never forget to check the mother to check for her carrier status, because that is very important to protect her at least in her next pregnancy, so that you can do a prenatal testing. Now this is a newer group of disorders called as mitochondrial disorders. We usually suspect mitochondrial disorders when you have children. When you see children where there is multiple system involved in a single child at a very early age. So mitochondrial disorders usually occur due to mutations in nuclear genes or mitochondrial genes. And always remember, mitochondrial genes are always inherited by the children from their mother only and never transmitted from the father. And the peculiarity of these disorders is that even different children in the same family can have different severity of the disease depending on the amount of mutated mitochondria they inherit from the mother. So this is a slightly complicated thing, but what they actually there is a theory called the mitochondrial bottleneck. According to this, the primordial germ cell in the mother consists of various oocytes, and each oocyte consists of different levels of mutated mitochondria within them. So the severity of the mitochondrial disease in a child always depends upon which oocyte has fertilized. So a heteroplasmy level of more than 70%, that is when the mutated mitochondrial level is more than 70% in the oocyte, the severity of disease will be more in that particular child. So both sexes can be affected in a mitochondrial disease, though inheritance is only from the mother. An example includes Leigh disease, Leber's congenital amaurosis, few of them. Now coming to the decision of which test to do for what. So that again depends upon what you are suspecting. So if it is a chromosomal disorder, you have various types. We all know about karyotype, we know fish. Then we have newer tests like microarray, which is nowadays being used by, I think, most of us. And the advantage of doing a karyotype is that you are studying all the chromosomes at one go. But the problem is that you are not able to detect any micro deletions or micro duplications cannot be detected, and you are able to look for deletions only of more than 5 mbp. In the case of a fish, you can check for micro deletions, but only targeted regions are being checked. That is, only specific chromosomes are being checked in a fish. And then you have microarray, where you check all the chromosomes. You are able to detect micro deletions, but the problem is that you cannot detect any structural anomalies within the chromosomes. Then you have your multiple ligand probe amplification, or the MLPA, which is again a technique specifically used for checking specific chromosomal anomalies. So always remember that you can order a fish or an MLPA only when you have a definite diagnosis. In cases where you don't have a definite syndromic diagnosis, it is always better to go for tests like microarray, because that will be detecting various unknown microdeletion and micro duplications. But for common things like your trisomies, your Turner, your Klinefelter, you can go for either a fish or a karyotype, and it is easy to, because you will get the results faster. And the samples which you have to collect, you all might be knowing, for your karyotype and fish, you should collect blood in a sodium heparin vacutainer. And the case of a microarray and an MLPA, it should be always only in an EDTA vacutainer. Then you have your single gene disorders, which are further classified into, the tests are classified into a clinical exome, also known as a targeted panel sequencing, where you are studying known genetic disorders, known disease causing genes, around 6,000 of them, and you target only the exons. And this is mainly ordered for diseases like, for example, a Noonan syndrome or a Rett syndrome or osteogenesis imperfecta, where you have a known number of genes. So you're sure that your diagnosis is osteogenesis imperfecta, but you don't know to which gene it belongs to. So you can order tests which are called a targeted panel testing. Then you have your whole exome sequencing, where you test for 25,000 plus genes. So this is a test that we order where you have multiple differentials to a condition, where you are not pretty sure as to what peculiar disease you are dealing with. Like, for example, a neuroregressive disorder, where you don't have a specific finding either in the MRI or let me say other tests which you have done. Then you have whole genome sequencing, where in the other tests they were only checking for the exons. In whole genome sequencing, we are studying both the exons and introns. So that is useful in cases where in either your whole exome or your microarray you have not been able to come to a diagnosis. Then we have tests like MLPA, which is specific for specific diseases and specific genes only. For example, SMA or a Duchenne muscular dystrophy, where an exonic deletion or an exonic duplication is the etiology. Then you have your triplet prime PCR studies, which are specifically done for triplet repeat disorders like Fragile X, Huntington's disease, and myotonic dystrophy. Always keep in mind that disorders like due to an exonic deletion or disorders due to a triplet repeat disorder cannot be detected in your whole exome. So if you are suspecting an SMA, if you do a whole exome, you might get it as a normal result. Or if you are suspecting a Fragile X and you are sending a whole exome, again you will get the normal result. So these tests are very specific for these disorders. Now these are last few slides about autism. All of us might be seeing at least 2 to 3 children with autism nowadays in our day-to-day practice in our OP. So the interesting fact about autism is that it's only in around 40% of cases there is a clear genetic cause for autism. Rest of the cases are of multifactorial origin, and in cases where you don't have a reason, the recurrence risk for siblings is 3 to 10%, and when there are more than 2 children in a family with autism, the recurrence risk is 30%. So this is just a tabular flowchart presentation, where as I've already told, only 3 to 10% is associated with a chromosomal disorder, and 10 to 20% is associated with a single gene disorder. Around 70 to 90%, all your tests might come back as normal. So any child with autism, if it doesn't fit into a specific syndrome or a specific diagnosis, for all males, definitely you should check for Fragile X. So often Fragile X children do not fit into your typical textbook diagnosis. We have a lot of children who don't have those typical long face and flared pinna, but when we have sent for a Fragile X, it has come back as positive. So all males with mental retardation and autism always order TP-PCR for Fragile X. Again, children who come with dysmorphism or multiple anomalies, you should suspect a chromosomal etiology, and you can go for a microarray. And again, in single gene disorders, you can go for a targeted panel testing. If you are suspecting a syndrome or a metabolic or a mitochondrial cause, you should go for a whole exome or mitochondrial panel. So this is just an exhaustive list of lot of single gene and chromosomal disorders where autism is a main recognized feature. Now finally, few examples. This was that cute little child which I showed you in my first slide. This child was the first child of non-consanguineous couple, born to a 40-year-old mother, had hypotonia, head control attained only at around 8 months, has upslant of eyes, low set ears, and on examination had bilateral simian crease. So this is nothing but Down syndrome, where in karyotype we have got 3 chromosome 21. This is another child seen in the pediatric cardiology ICU, a third child of non-consanguineous couple, antenatally detected to have a complex heart disease, had IUGR, birth weight was 2 kg, on examination had a hairy forehead, broad hairy forehead, microstomia, and a clenched fist. This was a child with Edward, trisomy 18. So these are certain large disorders in the chromosomes, large duplications. So in such cases, karyotyping is the test that you need to order. Now another thing is, in Down syndrome, now also it's not always necessary that you should go for a karyotype. Karyotyping in Down syndrome is important, specifically for counseling in the parents before their next pregnancy, because we all know that there are translocation type of Down syndrome which can recur in subsequent pregnancies, wherein you may have to do the karyotype of the parents. Now this is another child, again seen in the cardiology department. This is their first child with history of some developmental delay. Child is dysmorphic. You can see child has periorbital puffiness. Child had a very friendly personality. And incidentally detected murmur led to an echo examination in the child, and echo showed a supravalvular aortic stenosis. And child had hypercalcemia, a brief period of hypercalcemia in the newborn period. So this is the typical Elfin facies child with Williams syndrome. So this is a known microdeletion syndrome where the test for choice is a FISH or a fluorescent in situ hybridization, wherein you use fluorescent signals for various chromosomes. So here the two green signals are corresponding to the long arm of 7, and the pink signal is corresponding to the locus of 11.2. So you see that in one chromosome 7 the pink signal is present, and in the other it is absent. So that is the 7q11.2 deletion syndrome, or the William. Now these are siblings seen in neurology. One is a 10-year-old, the other is a 11-year-old with global developmental delay, born to non-consanguineous parents. These children have not attained speech. The child has both the children have a puppet-like walk. They have hand flapping. They have very bad seizures, not controlled by anti-epileptics. They have a fair complexion, long face, long nose. So this is children with Angelman syndrome. Here again you do a test called FISH, where you see a deletion in the chromosome 15q. Another child, a 1-month-old baby, heart disease detected soon after birth, tetralogy of Fallot with a right arch, had history of hypocalcemia on day 8 of life. On examination has a prominent nose, we call it as a squared nasal tip, has microstomia, micrognathia. So the hypocalcemia off with right arch gives a clue to the disease, that is DiGeorge syndrome. So these are all microdeletion syndromes where the test of choice is FISH, or even you can go for a MLPA. Then we have a lot of other syndromes. This is a Cornelia de Lange syndrome. You have a Treacher-Collins syndrome. You have this child with Noonan syndrome. Another child with mucopolysaccharidosis. These are all known gene disorders. For this, you can go for, your test of choice would be a targeted panel sequencing, or you can go for a whole exome sequencing, because these are all known disorders. Then finally, we have certain other disorders like associations. For example, VACTRL, that is a non-random occurrence of 2 or more anomalies by chance, wherein this is a developmental disorder where you do not need to go for a genetic test. Or you can have something called a sequence, which is a pattern of anomalies resulting from a primary insult. For example, a Potter's sequence due to severe oligoamnios or non-functioning kidney in the baby, or a Peary-Robin sequence. But Peary-Robin sequence is an exception. You can see it in association with some gene-related disorders or chromosomal disorders like DiGeorge. So finally, majority of neurodevelopmental disorders has a definite genetic etiology. Think twice, thrice before labeling any child with a cerebral palsy. And in critically ill children, always counsel the parents regarding need for genetic testing, and if they are not ready at that point, try at least to store the blood samples for a test at a later date. Genetic counseling is must in any consanguineous marriages, and especially when they have a family history of genetic disorders. And multiple anomalies seen in any couple in pregnancy. Priority is not termination. Always try to obtain samples of the baby either in utero or after termination, again for storage of DNA for future tests. So critical samples always important. In suspected metabolic disorders, always collect a urine and blood sample before you start correcting your metabolic imbalance, because that is important for biochemical diagnosis of the condition. Always collect EDTA samples or at least blood spots on filter paper for future testing, genetic testing, because you can isolate DNA from blood spots. And in the case of newborns where no other sample is available, even an umbilical cord bit or a dry desiccated umbilical cord itself is enough for isolating DNA for tests. And for suspected skeletal dysplasias, always take an X-ray, because that's an important clue to the diagnosis. Clinical photographs, very important. And also try to go for an autopsy in cases where you don't know the cause of death. Thank you.
Thank you.
Thank you, Dr. Danya, for your eloquent speech. The crowd is now open for questions.
Thank you, Dr. Danya. Very informative lecture on how to approach suspected genetic disease based on history and then relevant clues from the examination. You have made it very clear what test to order when. So that becomes very challenging, because unless we choose the appropriate test, as we are told, we may not get the right results. One question to you is, can you please tell us about that umbilical cord bit storage?
Yeah.
How do we do it?
In the case of like a newborn baby who is like dying in your NICU, where you are unable to take a blood sample, like already brought dead or something like that, or child is circulation is very much compromised, you can take an umbilical cord bit. A small bit of the umbilical cord can be cut and you can put it in saline, and it can be sent to any lab. Anyway, in Manipal they have facility for DNA isolation, or any labs which do genetic testing can isolate DNA from an umbilical cord. We have even cases where people have come with both their children having died due to some disease, but they had the they had the ritual of storing the umbilical cord. So they had brought us a dry desiccated umbilical cord, and we have isolated DNA even from the desiccated umbilical cord. So that is also possible. Just a bit of umbilical cord, at least 1 centimeter, is enough for isolating DNA.
Thank you. Any questions from the audience?
Thank you, Dr. Danya. It was an excellent talk. Rather than a question, it is a comment. So on the other side, I'm a developmental pediatrician. We see a lot of families coming with a lot of genetic tests. Okay? So my suggestion is we may need to do genetic tests as a lot of indications that you have suggested. At the same time, let me encourage to have some sensitivity, because we see families breaking up. So we see fathers abandoning mothers. Okay, so just a caution and a sensitivity. As we move on with more and more advanced technologies and genetic testing, we shouldn't lose our clinical touch. Thank you.
Yeah, that is very much correct. Actually, with the advent of genetics, actually the clinical examination part has actually come down a lot, even among our undergraduates, where the students are not at all ready to even examine the child in detail, or often most of the cases referred to us will not be having any differentials. But always in our clinic, we always have differentials when we send for a genetic test. You should have a differential diagnosis or a clinical diagnosis in your mind when you send for a genetic test, because all of you know that when the genetic result comes, they might be giving lot of variants in lot of genes which may not have any relation to the child's disorder. So always our clinical skills should always be there, even though we have umpteen number of tests. That is very important. We should have a diagnosis at hand.
Thank you. We request Dr. Suchita Rao to present the memento to Dr. Danya. We invite Dr. Dinesh Nayak, IIP President Udupi, to present mementos to Dr. Edwin Dias and Dr. Suchita Rao. The next session is a symposium on GI disorders in children. We are privileged to welcome Dr. Vijay Kumar, Professor and Head of the Department of Pediatric Surgery, KMC Manipal, and Dr. Jayashree, Associate Professor, KMC Mangalore, to chair the symposium. With great pleasure and honor, we invite Dr. Maya Pitambaran, Consultant Pediatric Gastroenterologist, Lakeshore Hospital, Kochi, and Dr. Moinak Sen Sharma, Pediatric Gastroenterologist at Sanjay Gandhi Postgraduate Institute of Medical Sciences, for the session.
Moving on from genetics to systemic pediatrics. So now we'll start on with the GIT. The first topic is the approach to chronic diarrhea in children. Probably one of the common problem in pediatrics. Dr. Maya Pitambaram is going to speak on this topic, and she's a MD Pediatrics and DNB Gastro, MRCP. She has 6 years of pediatric and 13 years of gastroenterology experience. Presently, she is working as consultant pediatric gastroenterology at Lakeshore Hospital, Kochi. Over to you, ma'am.
Thank you. Thank you, sir. Good afternoon to all. At the outset, I thank the Department of Pediatrics of KMC Manipal for this invite. And being a proud alumni, when Sunil sir invited me, I jumped at the opportunity to come back to Manipal. So here I'm going to talk about an approach to chronic diarrhea in children. Chronic diarrhea is something all of us have come across at some point of our practice. So, and the long chapters have been written on chronic diarrhea, so it is difficult to bring everything into in this short time. But I would try and how we approach a child when he presents to us with chronic diarrhea, and I've picked up a certain small case snippets and how we go about it. So, starting with the definition, we all know when we call it as diarrhea, when there is an increase in the stool weight, more than 10 grams or more than 200 grams, or there is a change in the frequency, that's more than 3 or more stools per day, or when there is a change in the consistency, when there is when the stools becomes loose or liquid stools. Now, moving on to the definitions. Persistent diarrhea is an episode of diarrhea which is presumed to be of infectious etiology, starts acutely and lasts longer than 2 weeks, whereas chronic diarrhea usually has more of an insidious onset, non-infectious etiology, and again lasting for more than 2 weeks. And then we have a small section which is called an intractable diarrhea of infancy, where again you have diarrhea lasting for more than 2 weeks in infants, and more often they present less than 3 months of age. Now, diarrhea in children, one thing is there is an age-related spectrum. So depending on the age of presentation, we can say, okay, we can actually narrow down many of our differentials. There is also this entity of congenital diarrheas, and also, unlike in adults where we have a very low threshold to go into endoscopy or procedures, here we try to make a diagnosis in non-invasive methods, and so a stepwise approach would actually reduce the need for endoscopies, and also nutrition has a role in many of these disorders. So the causes, if you generally classify them, it could be GI causes and systemic causes. I mean, a simple UTI, septicemia, nephrotic syndrome, hypertension, adrenal insufficiency, all of them can have diarrhea as some of their presentations. GI causes, it could be small bowel causes, it could be large bowel, it could be pancreatic, it could be biliary. So how are we going to narrow it down to say whether it is a small bowel, whether it is large bowel, or it is pancreatic? How are we going to pick which one? So just a quick approach to say how can we make a differentiation between a small bowel and a large bowel diarrhea. Small bowel diarrheas are typically large volume, bulky stools. They have fewer numbers, like 4 to 6, whereas large bowel diarrheas, they are small, more frequent diarrheas. So also, because there is involvement of the rectum, they would have rectal symptoms like urgency, tenesmus. Presence of blood and mucus is more in favor of a large bowel diarrhea, but malabsorption, weight loss, they are all more in favor of a small bowel diarrhea. Again, the location of the pain. Many times the periumbilical pain may be a clue telling us that this could be a small bowel onset, whereas in large bowel most often you find a hypogastric pain. Now, another way of looking at the diarrhea or approaching it is what is the kind of stools? Is it a watery stool? Is it an inflammatory stool? Is it a fatty diarrhea or fatty stools? So, watery stools can either be a secretory or osmotic. So, how are we going to differentiate that? Osmotic because once we differentiate that, then your differentials or your diagnosis narrows down. So if you have an osmotic diarrhea, the classical example is a secondary lactose intolerance. Here, what is the response to fasting? If the diarrhea stops with fasting, then it is likely to be osmotic diarrhea. The stool volume, whereas in secretory diarrhea, the diarrhea continues. If you also, the stool volume, you have large quantity of stools being formed in secretory diarrhea, so the volume could be more than 200 ml in 24 hours. Also, when you have to look at the stool pH, there is presence of reducing substances, all that is pointing, or the stool osmolality is increased in osmotic diarrhea, whereas this stool pH, reducing substances, all that is absent in secretory diarrhea. Now, this is what I said. Accordingly, we are able to narrow down our diagnosis. So, osmotic diarrhea, classical example is a secondary lactose intolerance, whereas secretory diarrhea can be infections, neuroendocrine tumors, and in smaller children, it could be congenital chloride diarrhea, etc. Now, what are the pointers telling that this could be an inflammatory diarrhea? One, as I said, there is presence of blood and mucus. There could be systemic symptoms like fever. There may be elevated inflammatory markers like ESR, CRP. There could be an elevated stool calprotectin. The usual examples or the common examples of inflammatory diarrhea is your classical inflammatory bowel disease. It could be infections like tuberculosis, Clostridium difficile. It could also be lymphoma. What about fatty diarrhea? The mother would or the child would say, my stools are greasy after I go to the washroom. Sometimes you may find there is classical oily droplets. The difference between malabsorption diarrhea and maldigestion diarrhea is in malabsorption you find that the stools are greasy, frothy and offensive. Voluminous stools are there in malabsorption. Whereas in maldigestion you find that the stools would have classical oil droplets, which is seen in pancreas like a chronic pancreatitis, cystic fibrosis or biliary causes. Whereas malabsorption, the classical example is a celiac disease. Now again, age. Age is again giving us a clue. Okay, what are the differentials we should keep in mind? So common causes of chronic diarrhea in less than 2 years of age. One, it could be the most common cause is a lactose intolerance. So it could be allergic colitis, it could be celiac disease. In young age, we should always keep the possibility of immunodeficiencies. Short bowel syndrome, especially in babies who have had surgeries during their neonatal or in early infancy, lymphangiectasias, acrodermatitis enteropathica. And in children less than 3 years, toddlers' diarrhea is also differential. Uncommon causes, I have put intractable diarrhea, yes, they are uncommon, but now we are coming across more and more of IBDs. Infantile IBDs are being more and more recognized. Then there are some other uncommon causes. Now just one slide on intractable diarrheas. Those are those congenital diarrheas who present very early in the early newborn period, and they have protracted diarrhea lasting more than 2 weeks. They have a very high mortalities, and they may be associated with villus atrophy or without villus atrophy. That is in that you have your congenital sodium diarrhea, chloride diarrheas, autoimmune enteropathies, etc., or your microvillus inclusion disease. Now, what about diarrhea in children who are older than 2 years? The classical example is your inflammatory bowel disease. You have GI tuberculosis, parasitic infections, celiac disease, immunodeficiencies, pancreatic insufficiencies, and so on. Now, a good history, an approach, and a lab examination, a clinical examination, which we have learned in our pediatrics, is definitely going to help us to narrow down many of our differentials. So details of the diarrhea is associated systemic symptoms, the growth, the extraintestinal manifestations, associated infections. If do they have extraintestinal manifestations like aphthous, arthritis, erythema nodosum, do they have infections at other sites like respiratory, skin, ear infections? The diet, did the diarrhea start after onset of milk? Did the diarrhea start after onset of weaning? What is the family history? Examination, we've all been taught how to do a head-to-foot examination during our pediatric training. So we should do a proper anthropometry, look for pallor, look for clubbing, look for oral pigmentations. It could be Addison's disease, look for perioral rashes, look for extraintestinal manifestations, look for signs of nutrition and vitamin deficiencies. Do not forget to examine the perineal area in a child who is presented with diarrhea, because many times that could be a clue. So again, those are the red flag signs we just talked about. Sorry. I think I can... can you just go back? I don't know what happened. Just give, yeah, just give me that. So the lab test, which could be looking for anemia, look for lymphopenia, look for thrombocytosis. It may be a marker of inflammation. Look for pan-hypoproteinemia, look for hypoalbuminemia, CRP, ESR inflammatory markers, immunoglobulin profile, acquired immunodeficiencies, serology for celiac disease, according to the specific setting of the case which presents to you. Stool examination is equally important. Now, once we have gone through the history, the examination, and the lab, you could easily characterize them. Is it a malabsorptive type of diarrhea? Is it an inflammatory diarrhea? Or is it something else? So once you have, if you have not reached your diagnosis with your lab test, yes, if you are thinking about a malabsorptive diarrhea, think like a celiac disease, an upper GI endoscopy is planned. Or if you have you're suspecting an inflammatory diarrhea like an inflammatory bowel disease, you plan a colonoscopy with or without an endoscopy. And some situations, you may also require a small bowel imaging like a CT enterography or an MR enterography. Now, moving on to some of the case capsules. So here you have a 7-month-old child who is presented with diarrhea of 2 months duration. The child had blood and mucus in his stools, which was used to pass very frequent stools. And because this child was also bottle fed, he has received multiple courses of antibiotic, thinking that this is an infective diarrhea. He also had eczematous skin lesions, and his weaning was started at 5 months, and there was no history of otitis or any other skin infections or extra intestinal infections like otitis or skin infection, but the child was definitely failing to thrive. So the child was irritable, the child was pale, there was pedal edema, there was eczematous lesion, the liver was mildly palpable. So what are the possibilities are we considering in this 7-month-old child who has presented with an colitis-like presentation with blood and mucus diarrhea? So here you have one of the possibilities, as this child has been exposed to cow's milk. So it could be a cow's milk protein allergy with an associated atopic dermatitis. The child also had some skin lesions, so that could be an immunodeficiency. Could it be an infantile IBD? Could it be acrodermatitis, because there was also skin manifestations. So we did an investigation. Here his hemoglobin was low. He had low albumin. We did an immunoglobulin profile, which was more or less normal, only mildly elevated IgE. No, HIV was negative. So in this child, because we had multiple differentials in mind, we did a colonoscopy and we found that he had multiple aphthous ulcers in the rectum and in the left colon, and the biopsy showed plenty of eosinophils in the colonic mucosa, and he was diagnosed to have allergic colitis. And the most common cause of allergy at this age is cow's milk protein, and this child did have cow's milk exposure. So we put him off cow's milk, and he started improving. His albumin improved, his weight gain improved, his skin lesions also improved to some extent. So cow's milk protein allergy, they would present with diarrhea. Sometimes they did not have blood, or they could have blood in stools. They may have abdominal pain. Sometimes they would just present with unexplained iron deficiency anemia. Most often we would have, like in this child, a history of cow's milk protein exposure, they might have atopic eczema, etc. associated. The gold standard for diagnosis is the double-blind placebo-controlled food challenge, where you exclude the milk, then you reintroduce and see how the symptoms recur. But in this child, as he had more complicated presentation, we actually went ahead and did a colonoscopy. So management, as I said, strict avoidance of cow's milk. Exclusion if the baby is breast milk, yes, we have to insist the mother has to exclude cow's milk from her cow's milk, and cow's milk protein containing other food items in her diet. There are also formulas like amino acid formulas, extensively hydrolyzed formulas in the market which we can use. And soy protein, just because the child has cow's milk protein allergy, we do not recommend soy protein, because around 10% of them could have cross reaction to soy protein as well. And we slowly start reintroducing the cow's milk at 6 months or 1 year of age. So consider cow's milk protein allergy in infants who present with chronic diarrhea without rectal bleed. And we should remember that sometimes cow's milk protein can be secreted in the mother's breast milk. So they need not, even in this presentation can come even in babies who are exclusively breastfed. Now moving on to the second case, this child is a 12-year-old child who presented with diarrhea of 2 years, and after one year she started having abdominal pain, a typical periumbilical type of pain, which is worsened postparentally suggestive that there could be a subacute obstruction. The child was also short stature. She had anemia. So with this, what are the possibilities we keep in mind? A 12-year-old child, diarrhea, there is abdominal pain, and this has been going on for some time, telling us that the child is short. So here we went again and did these investigations. You could see that the child is anemic, there is thrombocytosis, there is increased in CRP, there is low albumin. So what are the possibilities we consider here? Could this be an inflammatory bowel disease? Yes, possible, because here you have a diarrhea, you have abdominal pain, there is also elevated inflammatory markers. So we went ahead and did a colonoscopy, and here you can see there are multiple colonic ulcers scattered all throughout the colon as well as the ileum, with long deep ulcers suggestive of, with normal areas in between suggestive of Crohn's disease, and biopsies were also suggestive of Crohn's disease. So whenever we have suspecting Crohn's disease, we should also do a small bowel imaging. So we went ahead and did a CT enterography. There did show a thickening of the terminal ileum and a rectosigmoid. So many times a growth failure or a reduced growth velocity may be the first clue telling us that there is an underlying chronic pathology going on in these children. So chronic diarrhea in association with abdominal pain, especially with features suggestive of subacute obstruction, associated perianal symptoms, associated anemia, associated inflammatory markers, hypoalbuminemia, presence of thrombocytosis, growth retardation, all this, think about inflammatory bowel disease. So this is another child, 10-year-old child, again presented with a history of blood and mucus diarrhea. There was tenesmus. This child has received multiple courses of antibiotic. During the course, he also started developing joint pains or arthritis, bilateral knee joint swellings. He was pale, he had arthritis, he had anemia. See, look at his inflammatory markers. His CRP was high, his albumin was borderline low. We did a colonoscopy, and the colonoscopy showed pancolitis with diffuse involvement, and the biopsy was suggestive of ulcerative colitis. So this child actually had a GI symptom with an extra intestinal association. It could be, in this case, it was a joint manifestation, it could be erythema nodosum, it could be pyoderma, it could be an oral aphthous ulcers, it could be an eye involvement or scleritis. So when you have a chronic diarrhea in a child who's not responding typically to antibiotic, there is associated extra intestinal manifestations. Again, start thinking about inflammatory bowel disease. What I want to bring out in this slide is, now we are, as we all thought earlier, that inflammatory bowel disease is a polygenic or multifactorial in its etiology. But over the years, we have, with the advent of genetic testing and more, we have realized that there is a small subset of children who are diagnosed with inflammatory bowel disease who are monogenic. So these children, as Dr. Danya alluded to, a genetic testing would help us in picking up these monogenic IBDs. So as the child is younger, the higher chance that there could be a monogenic onset of IBD. Now this is another 10-year-old boy who presented with short stature, delayed puberty. He had diarrhea of 2 years. There was anemia. There was mildly elevated inflammatory markers. His celiac workup was negative. There was hypoalbuminemia. So this child, we thought this could be IBD. But we did a colonoscopy which was normal, and an upper GI endoscopy actually showed there was villus atrophy, there was paucity of plasma cells, and there were plenty of trophozoites in the villus side of the. On the villus side, there were plenty of trophozoites, and this child was diagnosed with giardiasis. So this child had recurrent infections of the same infections. The child kept presenting with one or the other symptoms like esophageal candidiasis and things like that. So then we started working up for an immunological underlying possibility, and look at us, he had find cases of celiac much in Kerala, but I think it is there in many parts of the south, and in north they are very common. There are many experts sitting here on management of celiac disease. So this is a gluten sensitivity. They can present with chronic small bowel diarrhea, abdominal distension, anemia unresponsive to hematinics, temporal association to weaning or the introduction of gluten. All this may be a clue to us. A positive serology and a histological changes would help us in bringing the diagnosis, and the treatment is an absolute exclusion of gluten-free in the diet. Intestinal lymphangiectasis is yet another not so uncommon cause of small bowel diarrhea. They would present with anasarca. These children would have not just hypoalbuminemia, they would have hypoproteinemia along with lymphopenia is what this gives you the clue. They would also have fat-soluble vitamin malabsorption. So endoscopically, the snowflakes in the duodenum, the snowflakes in the duodenum is something which may give you a clue, and the biopsy will show the dilated lacteals, and they respond to the specific dietary interventions. A-beta lipoproteinemia, these children again have fatty diarrhea. They would have absence of ApoB lipoproteins, and the peripheral smear you can see that there is presence of acanthocytes. You can see those acanthocytes. So that would be that would be a clue to an A-beta lipoproteinemia. Immediately start doing a lipid profile, which would give you a clue, and they may also be associated with retinitis pigmentosa, ataxic neuropathy, etc. Now, all the diarrheas or presents to is this kind of complicated causes? Definitely no. Some of them are those simple toddler's diarrhea. Those are those chronic, non-specific diarrheas they come with, and these children actually, they do very well. They actually have a normal weight, normal growth. These diarrheas don't appear when the child is sleeping. So we have these Rome 4 criteria which would help us in coming to a diagnosis. So another simple common cause of chronic diarrhea is a secondary lactose intolerance, where there is villus atrophy and secondary deficiency of brush powder. Most common brush powder lactase, most commonly secondary to viral gastroenteritis. So sometimes this can also be associated with when there is villus atrophy, as in case of celiac disease, Crohn's disease, or giardiasis. And the classical symptom, we have all learned this explosive diarrhea with perianal excoriations, and the stool pH or reducing substance would give you a clue. Many times just a clinical history and a clinical examination would give us a clue about to diagnose. We don't need to do any of these stool tests or any further investigations. Mainstay of treatment is withdrawal of lactose. Now, this is how a quick approach, how we look into this algorithmic approach to a chronic diarrhea. So whenever a child comes to you, just see if the child has a normal weight, normal height, is it not nutritionally normal? Is this child take a good dietary history? Is the child on a high fructose diet? Yes, it could be a simple chronic non-specific diarrhea, or this could be a simple lactose intolerance. However, If the child has weight loss, there are systemic symptoms, the child has some alarm signs, blood and mucus diarrhea, weight loss, growth stunting, then start doing the lab investigations. Initially go in a stepwise way, go for non-invasive intestinal function test, and now if you think it could be a malabsorptive pattern, think about an upper GI endoscopy. If it's an inflammatory pattern, think about a colonoscopy without an OGD. And thus you can go ahead and finally come to a diagnosis and you can give the specific treatment. So chronic diarrhea, it's a mixed bag of disorders. In evaluation of a child, you would have to give due importance to the age of presentation, the type of stools, whether it is large bowel diarrhea, it's a watery, fatty or inflammatory diarrhea, is there an associated symptom, is there a growth-associated growth affection, is there an extra intestinal manifestation. All this is going to give us a clue about how to approach this child, and a stepwise approach is ideal, and earlier diagnosis and treatment definitely prevents complication and improves the prognosis of these children. At this, I would like to acknowledge my teachers humbly here who have held our hands, who has nurtured us, who have taught us the basics of pediatrics, and from there we took off into different super specialties. Thank you all. Thank you for nurturing us, entrusting us with the knowledge that we will cherish forever. Thank you so much.
Thank you, Dr. Maya, for excellent talk. I'm sure it's going to benefit the postgraduates. The topic is open for discussion. Any questions?
So, Dr. Maya, I had a doubt how exactly the milk protein has to be reintroduced, like milk protein ladder, anything is there?
Yeah, normally in children who present less than 6 months, it is better that we wait for a year and then reintroduce. So we usually, practically, this is what we follow, where we give 5 ml, 10 ml of milk and see how the child is, and weekly slowly go on to 1 ounce, and then slowly we can start. But we have seen that when we give this counseling, we have to tell them, you should not just tell them milk exclusion. You have to tell them it's milk, butter, ghee, including the payasams, the biryanis, everything has to be excluded. And the mother who is on, if she's feeding, she also has to be very, very strictly off the diet. Otherwise, you won't get that response, and your reintroduction may be delayed. So those who present later than 6 months, generally we can try reintroduction after 6 months of withholding. Otherwise, young children, better to wait for a year.
Any particular criteria is there, how exactly they should go up on the ladder of introduction?
Usually this is what we practice. We get around 5 ml, 10 ml, 30 ml, and then weekly, initially weekly, then you can make it alternate day and slowly start introducing the milk daily.
Oh, thank you.
Because I'm from surgical background, I'm interested to know any surgical conditions you have come across which presenting as chronic diarrhea.
The hot springs sometimes, they would have the secondary diarrhea like presentation. They would have chronic constipation, but when they present to you, they would be with diarrhea like presentation.
Adding on that, like I have seen one patient with the tubular duplications of the jejunal ileum, which is presented with the recurrent diarrhea, not responding to any line of treatment. And one day, we had to open the patient because the patient presented with the obstruction. So incidentally, we could see a long tubular duplication. Probably that is a cause for...
Possible, because there could be some small bowel, SIBO like, it could be, there will be some SIBO and that would be causing the diarrhea.
Thank you.
Okay, sir.
Thank you, ma'am, for enlightening us with your words of wisdom. The next discussion is on approach to chronic liver diseases in children by Dr. Moinik Sharma.
So Dr. Moinik Sharma
is a pediatric gastroenterologist with the vast experience of 17 years, with 2 years of pediatrics and 15 years of pediatric gastroenterology experience. He is currently working in SGPGI Lucknow as additional professor under pediatric gastroenterology. His special interest is in endoscopy, cirrhosis, and Wilson disease. Over to you, Dr. Moinak.
This is a very humbling moment for me. Irrespective of my talk, this is where I started. This is 2006, and so many of you can identify yourselves in that. And little did I know that 17 years down the line, I'd be telling my own alma mater, my own teachers about all this. It's a very important event for me. I have done my undergraduate also from here and postgraduate, so all these teachers taught me twice. And I'm very proud of my lineage, because wherever I go, I keep boasting about the teaching and the training in KMC Manipal. So, Pushpa ma'am, if you can identify bald and fat, and so these are some of our previous batchmates, and who've made us do many night duties. Maya, lots of night duties with you. So if you look at the approach to chronic liver diseases, it's a simplified and broad overview. I'm going to keep this very, very simple because there are a lot of postgraduates here. Chronic liver disease is a broad term that encompasses chronic hepatitis and cirrhosis. And not necessarily you have to tease each other out. Cirrhosis is ideally a histologically proven condition. We say in day-to-day lives, okay, this is cirrhotic, this is non-cirrhotic, but ideally it's a histologically proven condition where you have telltale evidence clinically in the form of a shrunken liver, ascites, and things like that. Portal hypertension is not sine qua non to chronic liver disease, and it is just the increase in portal pressure which is evidenced by splenomegaly, varices, and a dilated portal vein. Portal hypertension does not mean chronic liver disease, but most cirrhosis will have some amount of portal hypertension already in it. There's a new terminology, and adults have a very, hepatologists have a very driven community where they come up with new terminologies, and we as pediatric gastroenterologists try to imbibe them, and they've come up with something known as a clinically significant portal hypertension, and that is a totally elastography-based diagnosis. There are new terminologies again that are important. One is decompensation. That means in any patient of a chronic liver disease who has ended up with ascites, encephalopathy, variceal bleed, it means to say he has decompensated. And further decompensation is now a terminology in vogue where it is one stage beyond cirrhosis where the patient has gone into some kind of a chronic condition, either a kidney injury or a refractory ascites, recurrent spontaneous bacterial peritonitis, or encephalopathy. Terminal liver diseases are also known as end-stage liver diseases or burnt-out cirrhosis, and recompensation is now a new term where the disease is cured or under control. So if your autoimmune hepatitis or your Wilson's disease is now doing very well, you would probably call that recompensated disease. So if you look at the usual onset, you look at infantile and childhood. These are storage diseases, glycogen storage diseases, lysosomal, genetic diseases, with some of which Dr. Dhania covered. And in that, from the liver point of view, we see the progressive familial intrahepatic cholestasis, bile acid synthetic defects, and biliary atresia. And there are so many surgical conditions that start in childhood, in infancy, and go on to childhood. And in childhood, another set of disorders present, and that is PFIC3, that is progressive familial intrahepatic cholestasis, non-alcoholic fatty liver disease. Now almost every city is seeing a surge of the same. Hepatitis B. Please remember, I have not talked about hepatitis C, because hepatitis C is something we see in children, but it does not cause cirrhosis in children. It takes 25 years actually to cause cirrhosis. So by then they are adults. So it's not a very big problem for us. and very importantly, Wilson's disease and autoimmune hepatitis. And someone straddling in between is tyrosinemia. Neither very young nor very old, but somewhere in between as a toddler, tyrosinemia type 1 can come in. Then there are some other diseases like congenital hepatic fibrosis, Budd-Chiari syndrome, and sclerosing cholangitis. If you look at causes of portal hypertension, the most important cause, as in contrast to the West, is we see extrahepatic portal venous obstruction. That's about 50 to 75%. Congenital hepatic fibrosis, which is a pre-sinusoidal condition. Then you have a sinusoidal, which is actually cirrhosis, steatosis, and storage disorders. Then you have veno-occlusive diseases, and post-hepatic, you have Budd-Chiari syndrome and constrictive pericarditis, many a times mimicking just like a liver disease. So, if I had to eliminate everything and just focus on the childhood chronic liver diseases, then 90% of the time I would find one of these conditions that are enlisted here to you. And this is actually the crux of pediatric chronic liver diseases. How to suspect, how to go about. So it's not no rocket science to say that there is a clinical phenotype to it. It's common for all disorders, that is, physical features of the liver, evidence of portal hypertension, stigmat of chronic liver disease, and decompensation. Then you have etiology-specific issues, and then you have, on investigation, you might see low albumin, coagulopathy, varices on endoscopy, a dilated portal vein, or you have very exuberant abdominal collaterals. So we go case-wise, and I'll take you through these cases and gradually explain what these are. So this is a 10-year-old boy, abdominal distension of a 3-month duration, and it was more in the upper part, then became generalized. So somewhere in your mind, you're thinking it might have been a hepatosplenomegaly, and now that it has become generalized, it must be ascites. There is a fluid tapped elsewhere, so definitely there is an ascites. There's a jaundice of 15 days duration without any prodrome. So if you explain each line, it would be organomegaly and ascites. Fluid tapped is definitely ascites, and conjugated jaundice because of this 15 days duration. So here, the inference is that the ascites has occurred, note, before the jaundice. That means he's decompensated already. There's an indolent process that is going on, but he's slowly deteriorating. Most likely this is not an acute condition, so is it a chronic liver disease? If you look at clinical presentations of chronic liver disease, you have a decompensated liver disease, where you have florid signs of chronicity. You have a subtle presentation, maybe or a long duration, where you have some clinical features of chronicity. Then you may have an acute presentation on an underlying CLD, and that is called as acute on chronic liver disease. Florid presentation. When you have jaundice, which is conjugated, and here I've written more than 6 months. This more than 6 months is hugely debated. It is more than 6 months from an acute process that has started. So if you've had an acute viral hepatitis, 6 months has gone by, it's a chronic liver disease. What is the relevance of the duration of CLD? Normally, we say more than 6 months, but there are conditions where within 3 months, the chronic liver disease has set in. So the duration of 6 months may not actually be well-fitting into the definition of chronic liver disease. So if you can see, this is a study from our own institute, where you see that 60% of the patients have actually presented within 3 months. They've had symptoms and they've presented as chronic liver disease, so the duration did not matter. Second is if you have a subtle feature. That means you have a jaundice, very small duration, which was conjugated, but you had a transient ascites which resolved, or an altered sensorium that recovered the patient from. You are very doubtful, and examination here should be very, very careful. It will give you a clue. Third presentation is pruritus. So it's a long-standing, early onset, intractable, sometimes familial pruritus. The jaundice in that can be recurrent or persistent, and these are cardinal features of biliary disorders which are anatomical or transport or defective bile acids. So here is a violently itching child. This is PF5C, progressive familial intrahepatic cholestasis type 1. He's violently itching, and the patients have a very poor quality of life. They can't sleep at night, they can't go to school, their mothers don't sleep, their fathers are out of work, and so many issues are there to these patients. And they all have livers which have chronic liver disease in them. The fourth presentation is asymptomatic. Many a times you're called in for a referral and it's just because there's an asymptomatic elevation in the transaminases, alkaline phosphatase, or a gamma glutamyl transferase. And this is incidentally detected. When you examine the child, you may find a hepatosplenomegaly or a shrunken liver. So it is a very, very subtle presentation. The fifth one is where you have a multisystemic presentation. That means either there's a family history or there's an obesity going on or there's systemic features like rash, joint pains, acne, or a multi-transfused patients where there is elevated liver enzymes and hepatosplenomegaly. So we go back to this 10-year-old boy. And one of the basics that all our teachers have taught us is, I think Nalini madam, you've always taught us, examine the SIB. So I give you a twist here. The twin brother also has a distended abdomen. There is no family history of neuropsychiatric autoimmune disorders. Patient is immunized for age, and there is no deterioration in the school performance, any handwriting. But the twin brother also has a distended abdomen. So we are not sure, but he needs screening or examination. Because of this family history, we wanted to know whether Wilson's or autoimmune could be a possibility, or hepatitis B. And there is no deterioration on school performance, so maybe it's not Wilson's disease, but we can't be sure. Let's see. So this is a likely decompensated disease, and family history is doubtful. When you talk about family history of CLD, it's very, very important to know that is it the same generation or the previous generation? So Wilson's disease patients usually present two SIBs, same generation, will have similar features. You will not have parents having Wilson's disease because that's only 1%. Parents having Wilson's disease, giving children to Wilson's disease is only 1%. But if you look at hepatitis B, C, congenital hepatic fibrosis, or any of these rest of the conditions, they are mostly in the same, also in the previous generation. So we've seen fathers and uncles with congenital hepatic fibrosis and the children also having the same. Autoimmune liver disease, very, very important. The child has autoimmune liver disease, mother has thyroiditis, father has adrenals, or is a type 1 diabetes mellitus. So very, very important to take the family history. So here are the twins. You can see twin A is slightly shorter than twin B. And I've taken this with permission. And this is what their livers look like. So twin A, who's shorter, has ascites also. And twin B just has hepatosplenomegaly. So we are sure this is a familial condition going on. When you have to examine patients, you have to look at the liver margins, whether they're sharp or irregular. Liver nodularity, it may be macronodular cirrhosis. And liver consistency, firm is not specific, it's just probable, but hard is usually found in congenital hepatic fibrosis. Liver span is usually shrunken, it's very specific for cirrhosis, but it is enlarged in so many other conditions like secondary biliary cirrhosis. So the biliary atresia that go on with successful Kasai later in the long runs always have nice big livers, but they are actually going gradually into secondary biliary cirrhosis. Differential enlargement where the left lobe is larger than the right lobe. In general examination, you look for bite spots, rickets, skin bleeds, xanthomas, phrinodermas, paper money skin, scratch mark, shiny nails. You look for stigmata of chronic liver disease, and with time we've been taught and now trained to say that if you talk of chronic liver disease stigmata in children, don't talk about the gynecomastia, don't talk about Dupuytren's contracture, and don't talk about the secondary sexual characteristics, because these are very, very specific of alcoholic liver disease in adults. So we usually in children restrict ourselves to palmar edema, nails, and the spider nevi. Portal hypertension, spleen, veins, and ascites. Etiology specific. In Wilson's disease, look for a KF ring. Sometimes you find them in the naked examination. Gait and ataxia. Autoimmune hepatitis, acne, vitiligo, psoriasis. NASH, you look for acanthosis nigricans, and lichen planus in hepatitis B and C. And then you look at complications such as asterixis, hepatopulmonary syndrome, the saturation, and for clubbing. So this one slide in toto is for the postgraduates. If you have this checklist, you are not going to miss out anything in your examination, and nobody can actually fail you that you've missed one or the other signs. Here's just to show you, look at this caput medusae, exuberant caput medusae. The first child is actually, this one is a This one is actually a Budd-Chiari syndrome patient that was there, and he has exuberant collaterals, he has back veins. The third patient is ascites, then there's hepatosplenomegaly and tortuous veins over the back. I just put this slide because I've not done anything great. It's a very simple observation that I saw. Bite or spot, today it is there, after 7 days it is not there. And there is a ring around the cornea, and that is the chronic bilirubin ring. We just noted that, and it is just on our mobiles. But we thought we'll just try and see. So we put it in Journal of Pediatrics. They took it up as a discovering physical exam as one of those small snippets. So if you are seeing something on a day-to-day round basis, it's always nice to take photographs of the same and publish from time to time. This is Terry's nails. These are very, very important. Terry's nails. Always look at nails of any patient and hands of any patient. And this is the white nails that are there where the lunula has moved from its position because of the hypoalbuminemia. These are some of the other stigmata of chronic liver disease: Palmer erythema, spider nevi, gynecomastia, which I usually will not say in children. Bite spots, cave ring, rickets. This is a child with tyrosinemia who had rickets. He had a hepatosplenomegaly on examination and florid rickets. And this facies is suggestive of Alagille syndrome. They have sharp pointed chin and a broad forehead, and they have usually ductal paucity. So going back to the same condition, and this is our patient. How will I proceed? Step number 1 is to do an LFT, including a gamma-glutamyl transferase and a hemogram. Transaminases 2 to 3 times upper limit of normal is usually suggestive that there is a chronicity going on. But when you have that transaminase, you should not conclude with one LFT value that this is abnormal. You should have 2 or 3 LFTs after a period of 2 to 3 weeks to say, yes, these were there, they are long-standing, because normal viral fevers also cause some amount of LFT changes, and you may misinterpret them. And you should be sure that there is no acute viral hepatitis in the last 6 months. How do I proceed? Step 2. So once you've documented with your LFT, you do an ultrasonography, you look at the hepatobiliary part, and you proceed as per etiology. The regular etiologies that we usually send is hepatitis B, hepatitis C, ceruloplasmin, 24-hour urine copper, KF ring, and a whole lot of autoantibodies, namely the antinuclear, the smooth muscle, and the liver kidney microsomal LKM, and also the IgG, and a lipid profile if the patient is obese. Liver biopsy is not required in all, and it is usually we do cutaneous unless you're contraindicated with a coagulopathy or thrombocytopenia, where you need to do a transjugular lipid biopsy. What do you look for on ultrasound? You look at the portal cavernoma, patency. If you have a dilated portal vein, you have a hepatic veins and IVC, which is very important to diagnose Budd-Chiari syndrome, changes of cirrhosis in the liver, and changes in the biliary tract. Very important, upper GI endoscopy for varices and specific investigations for underlying etiology. In the liver function test, if you have hypoalbuminemia, less than 3.5 and an INR more than 1.5, it tells you it is a poor synthetic function. And ultrasound Doppler, I have just told you, there are some normal portal vein diameters, normograms that are available. You use the same. But in older children and adults, a portal vein diameter of anything more than 13 mm is always suggestive of an intrahepatic portal hypertension. So going back to this twin A is the proband where bilateral KF ring was positive, ceruloplasmin was 6.5, 24-hour urine copper was very high, and we started this patient on D-penicillamine. Sibling screen, also similar findings. We had to start the patient, that one also, on D-penicillamine. Do I require a liver biopsy? Only if you have ambiguity in diagnosis, that is not typically fitting. Autoimmune hepatitis, it is mandatory for diagnosis. In congenital hepatitis, mandatory. But in Wilson's, it is not mandatory. You can only do it if you want to do a hepatic copper. Hepatitis BC also not mandatory. NASH, Budd-Chiari, no. So we restrict ourselves to liver biopsy. Some of the cases you don't require. In this case, we particularly did not require. What is the role of transient elastography, which is a fibroscan, as you call it, on a day-to-day basis? You show a non-invasive measure of degree of fibrosis. It's not required in all cases, but it's very good for follow-up. So if you've documented a high fibroscan today, over the years you've treated, you document a lower fibroscan, tells you there is a reduction of fibrosis. Liver biopsy, transjugular, percutaneous, you look at loss of architecture, bands of fibrosis, nodule formation, and very, very important, you have to tell your pathologist to do the reticulin stain to look at the fibrosis. This is just to show you what chronic hepatitis looks like. There is spilling of the inflammatory cells from one portal tract to another portal tract. These are nodule formations. Now, in our part of the country, Uttar Pradesh, where poverty is so marked, it's not as thriving and flourishing as South Canara and Kerala, where they have, this particular family had to choose which twin to give penicillamine. So the D penicillamine was preferentially given to twin B and not to the twin A. So for the next 18 months, this twin A was getting only half the dose, but twin B was getting a full dose. There was worsening in the liver disease. There were new set of neurological features, and this patient, finally, the second patient died, and the first twin survived, and the second twin survived. The first twin died, and the second twin survived, and this is how the compliance was over time. And this is the reality that bites us on a day-to-day basis in our country. So if you look at Wilson's disease, you have hepatic and neuropsychiatric presentation. They may overlap. 10 to 12% may have a neurohepatic presentation. And there is typically an age phenotypic presentation where younger the age, more of liver disease, older the age, more of neurological disease. And then you have a miscellaneous mixed bag of presentations such as renal tubular acidosis, Coombs negative hemolytic anemia, sunflower cataract, and so many other things. Hepatic manifestations are usually, it is going to be a decompensated cirrhosis, most of the patients, but some of the patients can come with acute hepatitis or an asymptomatic liver. The diagnosis, I don't need to tell you, it is hepatic manifestation. If you look at it from a liver point of view, KF ring, a high 24-hour urine copper, ceruloplasmin. Mutation is confirmatory but not mandatory. It's very, very cumbersome to do the mutation because there are some 700 different types of genetic defects, and liver histology is contributory. If you wish, you can look at this paper which we came out in 2019 on the Wilson's disease clinical practice guidelines, and 3 societies came together to make this guideline. And in this paper, we've changed the scoring system. We've called it the Indian modification of the modified Leipzig. And in that, some silly points were there which we took out, like genetics, which is not easily available, and we put in family history and stressed on that, which gave us more points, and you can score more number of marks and diagnose Wilson's disease in patients. This is also a paper that we wrote from our institute, and this is a very nice collection of 111 patients of hepatic Wilson's disease, and 85% of them did very well on, 70% of them did very well just on D-penicillamine. Some of them we had to add zinc to the regimen, and drug toxicity was there in about 11%. Okay, then you have this is a 5-year-old girl. Look here, there is a recurrent jaundice pattern, and the jaundice has just gone in between. She was anecteric for 2 weeks. She has mild pedal edema, and there is a liver that is firm, that is palpable. There is no spleen palpable. And if you look at it, the liver enzymes are raised. The INR was 2.3. It changed to, it decreased to 1.5. And somebody did the chronic liver disease markers and found that the SMA was 3+, IgG was 2,600, and portal vein diameter was normal, 6 mm. So the doubt in this child is, there is a girl child, she's relapsing hepatitis, there's increasing jaundice, the liver enzymes are 10 times the upper limit of normal, mild edema, small spleen, autoantibodies are high, and IgG is high, and everybody would jump and say that this is an autoimmune hepatitis, correct? So the thought process was the same. Is it autoimmune hepatitis? Shall we do biopsy? Shall we start steroids? And all that load of questions started. So the ceruloplasmin here was borderline, the urine copper was borderline. Over? Okay, so Wilson's disease. Now, when you look at the autoimmune scoring, you are able to fit into the autoimmune score, but we have not done the acute viral hepatitis markers, and this patient was IgM HAV positive, which looked like a chronic liver disease, but it was not. So, girl child relapsing hepatitis is known in 10% of HAV. Increasing jaundice known in relapsing hepatitis. 10 times upper limit of normal is also known as in acute viral hepatitis. And this mild edema is because it was iatrogenic, extra fluids were given. Autoantibodies can be false positive in acute viral hepatitis, and IgG doesn't mean much. 2 years, complete normalization, no organomegaly, we didn't start steroids. Now this case, I'm reminded of Nalini ma'am, once again. This is a child, 12-year-old child with relapsing jaundice of 2 months, intense itching, liver which is 3 centimeters firm, alkaline phosphatase which is very high, and anti-SMA is 2+, MRCP is normal. My resident tells me, sir, this is overlap syndrome, this is autoimmune sclerosing hepatitis. And we need to do a liver biopsy. Fine. Sometimes you have overzealous residents who come and say their diagnosis is done. But while doing the liver biopsy, there are lesions on the skin. The itching is because of that, and this was scabies. So we saved this child from a liver biopsy. This was actually hepatitis A with an unrelated scabies, and thank God we didn't diagnose this as autoimmune condition. And this is where Manipal's teaching comes back to you and helps you. This is a 10-year-old girl, jaundice, ascites, GI bleed, dilated tortuous veins, hepatosplenomegaly, free fluid. And this is a child with large portal vein, 13 mm. Liver biopsy shows interphase hepatitis. And if you are guessing it right, this is cirrhosis with portal hypertension, and the etiology is autoimmune liver disease. The ANA was 3+, 1 in 80 titers. And this is exactly what you find in autoimmune hepatitis. This is the crux, which is emperipolysis and rosette formation. These are very important features of chronic liver disease. I'll skip this slide. It's a 9-year-old girl with ascites, rapidly progressing, rapidly accumulating. And this, when we say rapid accumulation, it means you tap, 2 days later it's back. You tap, again 2 days later it's back. And there are dilated tortuous veins over the back. And this child actually has hepatic veins and IVC which are narrowed, and this is chronic Budd-Chiari syndrome with an IVC block. And believe me, this is a very, very rewarding condition to treat, because the intervention radiology will just open one of the hepatic veins and all of this will be, it will resolve. This is a 4-year-old child, incidentally detected hepatomegaly at 1.5 years of age. The family history, there is a chronic renal failure, and the paternal uncle is 20 years of age. And this child has had a hematemesis 1 month back. So it's a firm, sharp, regular liver. And when we did the LFT, we found the alkaline phosphatase is way higher than anything else. And that is a sign of congenital hepatic fibrosis. And there were small cysts in both kidneys. The liver biopsy showed bile ductal proliferation, ductal pleural malformation, and this was congenital hepatic fibrosis with polycystic kidneys. The reason why I'm showing you this case is the paternal uncle also had hepatosplenomegaly. He also had congenital hepatic fibrosis. We advised him, 20 years, so we advised him, go to the adult hepatologist, show. He didn't show. He died of a massive hematemesis about 2 years down the line. So this is how ignorant our community is. Approach to ascites, I think I will not, it is too much to understand now. Summary, when you look at the clinical differences, you look at, when you look at extrahepatic portal hypertension, cirrhosis, chronic Budd-Chiari, and congenital hepatic fibrosis, jaundice is characteristically absent in EHPVO, but the GI bleed is a marked feature. Encephalopathy and ascites are also not there. But in chronic Budd-Chiari, it is massively reaccumulating ascites. Liver is usually normal span in extrahepatic portal hypertension, but the others, you may have a shrunken or an enlarged liver. Dilated veins, you can have caput medusae and back veins. The conclusions, presentation, variety, jaundice is not mandatory. Examination is essential and thorough. Family history is an essential clue, and it raises an alarm. And think of the common disorders, 90% of the times you're going to be correct. and look for medically treatable disorders. If you go by a systematic way and you run the common tests, again, 90% of the time you're going to be right. And if you do follow judiciously the guidelines, 90% of the times you're going to be right. I can't help thanking all these teachers who have brought us up. And last year I was fortunate enough to meet all of them, and it was a blessing for me. Thank you to the entire department for the same. And thank you, Vijay sir. I'm meeting you after 15 years.
Thank you, Dr. Moinek, for that lucid talk and taking us through the basics to entire case workup and the details of chronic liver disease, various disorders. It was wonderful to listen to you. Now the topic is open for discussion.
Oh yes, trientine. How often I use is 10% of our Wilson's disease, more because it's a very expensive drug. D-penicillamine to trientine, the ability to chelate the copper is 4:11, that is the ratio. 11 times D-penicillamine is more potent than trientine. That is number one. Number two is trientine is extremely expensive, and the new generation trientine that has come, you don't require so much of storage problem, but earlier it was a huge problem of storage. The third thing, which I don't know if everybody is aware, is the government is now doing a rare disease project, and they are funding rare diseases. You can include your Wilson's disease on trientine on that. They will give you money for, I can't tell you how many number of years, but we've already started enrolling ours, and our patients have started getting trientine also. Very nice question, ma'am. We're struggling with these post-Kasai patients. Kasai potentiostomy, in its definition, if a surgeon has done more than 6 Kasai enterostomy per year, he's called as a high volume center, and we do about 30 Kasai potentiostomy per year or more probably. 50% only are doing well, 50% do horribly, and in that 50% who do well, in the long run, about 10 to 15 years down the long run, 90% will have features of exuberant portal hypertension, and they will require a liver transplant in the long run. So it's not a very nice disease to have, and Kasai therefore is just palliative and not curative.
Patient with biliary atresia already coming with the cirrhosis. Will you recommend Kasai or straight away go?
Straight away transplant. We are advising primary liver transplant to those patients who are already having features of either they're coming with cirrhosis on biopsy, or if they've had a dilated vein on the surface only, we know this is going to be cirrhosis. Inside, the surgeon is going to have a tough time to dissect at the porta because he's just going to bleed. So we say just go for a liver transplant.
And even post-Kasai, at what stage you will suggest that?
Post-Kasai, our cohort, they are earning their liver transplant in the second decade. That means at the 11th or 12th, around the time of puberty, their portal hypertension, probably because of the hormones, it's very, very high. That is when they are actually indications of liver transplant.
No, because I have 20 years post-Kasai, they're doing fine. You mean they need further follow-up?
Yes, sir.
Follow-up?
So the latest Japanese series that has come out, that is showing 90% of all the cohort of their biliary atresia by 40 years of age have required liver transplant. That is their experience. And yes, ma'am. Yes. So there is a chronicity that is always lingering with them. That's correct.
We request Dr. Vijay Kumar and Dr. Jayashree to present mementos to Dr. Maya Pitamjan and Dr. Monik Sen Sharma. We request Dr. Pushpakini ma'am to present mementos to Dr. Jayashree and Dr. Vijay Kumar.
Thank you, ma'am. Thank you, sir. We'll have a short tea break and we'll reassemble at 4:10. I have two more announcements. All those who haven't completed the registration formality yet, they may please complete it. It is very much required for the KMC credit hours. And I would also like to bring to your notice that we are going by the concept of vocal for locals. The kit bag provided to you is handmade by the residents of Hombelaku Rehabilitation Center, and also the beautiful mementos are made by Re-Sanskrit, that is an NGO for reinvigorate Sanskrit, which makes an effort to bring the pearls of wisdom from the Sanskrit to the modern world. We also have banquet which is held at Sharda International Udupi, and we are providing a bus from and to the venue. The bus will leave from the new international hostel entrance at 7 p.m.
PG കഴിഞ്ഞാണോ? ഞാൻ DCH വെല്ലൂർ ചെയ്തു. ഇവിടെ 2020 to 2022 ആയിരുന്നു എൻ്റെ MD. റിസൈക്കിൾ ബിൻ തന്നെ കാണത്തില്ലേ? ആ ഇല്ല. ഓക്കെ. Yours is tomorrow. Tomorrow morning.
I don't mind loading now, or I can load in the morning also.
Maybe I should just to keep it light in the morning because your first talk, no?
That's what I don't want it to be.
I don't know whose pen drive is it. This is Dr. Megha. She is also senior resident here.
Hopefully all of you will listen to my presentation and get motivated to do research. And it is very difficult for pediatrician to get pediatrician interested in research.
Just open this piece. USB drive.
Hello, check. Check, hello. Check, hello.
ಕಂಪ್ನಿಯವರೇನೋ ಮಾಡ್ಕೊಂಡು ನಿಮ್ಗೇನೋ ಸ್ಪಾನ್ಸರ್ ಮಾಡ್ಯಾರ ಅಂತ ಹೇಳ್ತಾರೆ. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ತೋರಿಸಿ. ಹಾಂ, ಅದೆಲ್ಲಿದೆ ಅದು? ಆಫ್ಟರ್ ದಟ್ ಔಟ್ ಹೋಗ್ಬೋದ? ಹಾಂ, ಇಲ್ಲೇ ಇರುತ್ತಲ್ವಾ? ಓಕೆ, ಬಟ್ PPT. ಆಯಿತು, ಆಮೇಲೆ
Dear delegates, we would now resume the session. The next talk is on vaccination in office practice. With immense pleasure, we now call upon Dr. Shamsuddin Ahmed Khan, Senior Professor and Head of the Department, Kanachur Institute of Medical Sciences, and Dr. UB Shetty, Consultant Pediatrician, to chair the dais. We invite Dr. Prashant, Head of the Department of Pediatrics, JSSMC Mysore, to enlighten us on this topic.
Shall we? Yeah, today's topic is this is an important topic which we discuss almost in every functions, CMEs and conferences. Nowadays, because of the government policies, we have left out with only few optional vaccines. Hence, it is important to know more about the newer vaccines. So I'm sure Dr. Prashant will discuss and highlight all about these newer vaccines. Now regarding Dr. Prashant, I don't think he needs any introduction. He is quite familiar and active in almost all CMS and conferences. He did his graduation in our KMC Manipal between 1993 to 96 and DNB Pediatrics in Jipmar 1997. He has vast experience, nearly 27 years of experience, and now he is professor and head of the Department of Pediatrics at JS Medical College, Mysore. His field of interest is vaccinology and infectious disease. With this, I present Dr.
Thank you, sir. Good afternoon, everyone. First of all, I thank the organizers for giving me an invitation to attend this program as a speaker. I feel blessed to stand before my mentors, teachers, senior professors. Pushpapani madam is there, Ranani madam. Morning I could see Vijaya madam's photo, Divakar sir's photo. I also have senior professors, Dr. Ravi, who is born with MD and acquired one more MD. He has two MDs, that's why his knowledge is double than mine. And I'm fortunate to have him as my senior colleagues in the last 27 years. And all my friends here. So, I hope many PGs are there. Postgraduates are there here? Okay, we'll start with the basics, we'll go fast. We the pediatricians are blessed as our whole life is spent with lovely children. We are always smiling. Though we work till late night, 10:30, 11, we are still smiling because we are with kids. What is the difference between vaccination and immunization? Vaccination is nothing but the process whereby you inoculate an antigen into the body. That is the process. Whereas immunization is the process where the body recognizes the antigen, produces antibodies, memory cells, all those things. That process is called immunization. It's the process whereby a person is made immune or resistant to an infectious disease by stimulating the body's own immune system to protect the person against subsequent infection. Immunization is a proven tool for controlling and even eradicating a disease. All of us know I have smallpox scar here. After that 1970, 75, those who are born, you don't have the smallpox scar, you only have a BCG scar. Because smallpox was eradicated from the world because of vaccination. Polio is almost eradicated. This is a nice Japanese theory, if you see here. So, they started, until vaccination was compulsory, lots of deaths were there, vaccine-preventable disease. Once vaccination was started, automatically death rate came down. But what they did from 1962 to somewhere in 1980, it was compulsory. Then they made it optional for the parents. Again, the death rate increased. This is the importance of vaccination. We have so many diseases, sporadic, endemic, epidemic, pandemic. Sporadic, all of you know, that occurs infrequently, irregularly, and usually without any geographic concentration. For example, tetanus, rabies. One boy bitten by a rabid dog in Manipal, one boy bitten by a rabid dog in Shumaga. So it's not to one place. Whereas endemic, it's always to one geographic area like dengue. We have dengue almost everywhere now, but malaria in Mysore we have not seen for almost a decade now. But I think malaria is still endemic in southern South Canada. Epidemics are the occurrence of more cases of diseases than expected in a given area or among specific group of people over a particular period of time. You have heard of influenza epidemic, meningococcal epidemic. During epidemics, the disease spreads rapidly and extensively by infection and affects many individuals in an area at the same time. Pandemic, all of you know what we have suffered 2 years back. It's nothing but a global epidemic. Disease originates in one country and then spreads to a number of countries. Latest is COVID. So if you take history of preventable diseases, Alexander, who died at 33, from 20 years, at age of 20, he became the king. For 13, he was on the battlefield. He almost touched the northern part of India also, but he died on the field, probably because of typhoid. Plague epidemic, you know, it has changed the face of the Greece civilization in 430 BC. Smallpox has been found in 3,000-year-old Egyptian mummies. So all these diseases are there since centuries and pre-AD, all those years. Spanish flu, 1918, the worst pandemic ever seen. 2009 pandemic and COVID-19. December 31st, 2019, most of us we were on the New Year's Eve celebrating, but one flash news came that Chinese officials informed 27 new cases of pneumonia. By January 11th, one death. January 30th, India had its first case within 1 month. That too from who I was studying in Wuhan University. He came to India. He was the first case. By March 31st, you have heard of Nizamuddin's congregation, and from there, those people who attended, many died on April 2nd. This is how a pandemic spreads. For postgraduates, we have types of immunity, two types, innate and adaptive. Innate is nothing but the ready immunity, what we have, skin, mucous membrane, hairs, all those things. It comes into play immediately on entry of the pathogen. It is non-specific. It is not limited to any particular antigen. Whereas adaptive immunity is provided by B and T lymphocytes. The innate immune system triggers the development of adaptive immunity by presenting antigens to B and T lymphocytes. This is the basic difference. Innate immunity, its response is antigen independent, whereas adaptive immunity is antigen dependent. Innate immunity, immediate response, where is a time lag between the exposure and maximal response in adaptive immunity. Innate immunity not antigenic specific, whereas this is antigen specific, and exposure does not result in induction of memory cells in innate immunity, whereas exposure results in induction of memory cells in adaptive immunity. Humoral immunity is the principal defense mechanism against extracellular microbes and their toxins. Cell-mediated immunity is for intracellular microbes. Active versus passive, all of you know, active immunity is acquired through natural infection or immunization, what we give vaccines. Whereas passive immunity, ready preparation, we use immunoglobulin, hepatitis B immunoglobulin or ready IV, IgG, all these are passive immunization. The first smallpox vaccine was produced in 1758, whereas 1977, the last case was detected in 1977 in Somalia. Earlier the vaccine, more the protection. If you see the babies coming from US, they all start at 2 months of age, first dose, that is 8 weeks. But in India, we are starting at 6 weeks because of the epidemiology of the diseases present in that area. You have all seen the success with polio, smallpox. Can any postgraduate recognize this girl? Last case of polio, 18-month-old Rusker, January 2011. So she was the last case in India, and WHO takes 3 years from there. If there are no other cases after that, they declare that it's not polio endemic, polio-free country. So we all, in April 2016, we shifted from trivalent polio to bivalent polio. On one day, we all changed the polio virus. We gave back the trivalent, we took bivalent because type 2 was eradicated. This is the IAP schedule. Vaccination in India, if you see, I can compare to your food. One is compulsory vaccine, which is UAP. All are supposed to take 1 meal a day, at least to sustain. This is UAP vaccine. There are so many optional vaccines. Your pocket is full. You can see Dr. Dinesh sitting there, whom we lost 5 years back, my close friend, Hassan IAP King. We had been to Bali. He was ordering a lobster or something. So if you have money, you can go for some special vaccines. This is the scenario in India, but other countries, they are insured, they are taking all the vaccines. Some special vaccines. Now in India, they are thinking of bringing into UAP rabies vaccine. As on now, whoever has a dog bite or pre-exposure, we are giving. If you want to go to Masai Mara, you have to take yellow fever vaccine. These are the special vaccines in India. We have live attenuated and killed, all of you know, various different routes. We will come to scenarios after the basics. There is BCG adenitis. Postgraduates, what will you do? What is the latest treatment? So, if it is non-suppurative, it's only observation. If it is suppurative, you can do fine needle aspiration, or even after that, if it's not improving, only excision. No ATT, no antibiotics. Dose of BCG vaccination, ideally less than 1 month, it should be 0.05 ml, and after 1 month, it should be 0.1 ml. Catch-up vaccination, till what age you will give? Suppose a person has come from US, he has not received BCG. IAP advice, till 5 years of age, you can do catch-up vaccination if the person has not received BCG. Should we do a Mantoux test before doing BCG? No need. Up to 5 years, you can just give away BCG. What is IAP recommendation regarding IPV? Anybody? How many doses? See, IAP says 0 dose polio, 6, 10, 14 weeks IPV, and again booster, 2 boosters between 16 and 18 months and 5 years. Totally 5 doses of IPV. Whereas UAP says 6 weeks, 14 weeks fractional IPV, and now they have added, the new thing is, they have added at 9 months also. Initially only 6 and 14 weeks were there, now they are giving one booster at 9 months. Hepatitis B, less than 2 kgs, what will you do? Baby's weight is 1.6 kilos. We give BCG and OPV, we wait for the child to complete 1 month to give hepatitis B. Now, recently they say you can still give hepatitis B at irrespective of the weight of the child and consider that as give in hepatitis B, don't consider the dose, continue with the regular dose of hepatitis B. Then, if mother is HPSAG positive, all of you know immunoglobulin and hepatitis B vaccination. This is important for students. If there is exposure, HPSAG positive patient and HPSAG negative, needle prick injury. If he is unvaccinated, totally unvaccinated, you give hepatitis B immunoglobulin and also start with the vaccination. Fully vaccinated and non-responder, no need to give hepatitis B, I mean even if HPSAG positive, nothing to worry. The antibody titers, if antibody titers are adequate, nothing to worry. Inadequate, give immunoglobulin and 1 booster dose of hepatitis B. This is very important for the students. Coming to Tdap vaccine, what is the recommended age? IAP. It's licensed, though it's licensed from 5 years, we are supposed to use after 7 years of age, Tdap. And boosters are not required. At 10 years, if you give a Tdap, follow it by TD at 15 or 16 years and then every 10 years. No need of Tdap again. 1 Tdap at 10 years is better. Catch-up vaccination for completely unimmunized children. Many children we get from Rajasthan side where they are totally unimmunized. Again, any PGs can answer this. Below 7 years, unimmunized child. You want to give DPT, how many doses? What will you use? So these are all the practical challenges we face in our clinic day to day. So below 7 years, give either DTWP or DTAP. 016 is the schedule. So unimmunized child 016, whereas above 7 years, give 1 dose of Tdap, followed by 2 doses of TD. That is 016 again. 0 dose is Tdap, then 1 and 6 are TD vaccine. Coming to PCV vaccine, a mother brings her 2-month-old child who has not received any PCV vaccine in the past for PCV vaccine now. Which one and how many doses? There are so many PCV vaccines. All of you know the dosage schedule. About 2 years, it's single dose. But only for pneumococcal 13 vaccine, it is single dose. Remember, if it is for Synflorix, if it is PCV 10, it is still 2 doses after 2 years also. This you should know. 22-year-old engineer comes to your clinic requesting vaccinations for meningococcal, pneumococcal, MMR and chickenpox as he is going to US for higher studies. Routinely we see. So, except meningococcal, pneumococcal, all others we give. But if there is a combination of meningococcal, especially Menectra and Prevnar or pneumococcal vaccine, we should not give on the same day. Give Prevnar on first day, 1 month later give meningococcal. Please remember this, don't give it both on the same day. Rotavirus vaccine age limit for the first and last dose, anybody again? First dose should be given before 3 months, 3 weeks. In IAP schedule, we are all private practitioners. Government schedule is different. They, in northern India, they say up to 1 year cover-up vaccination for thousands, but we can't take the risk. It's in our clinic, in our practice, it's 1-to-1. Parents have come to us with the belief that I'm going to take care of the child. So 3 months, 3 weeks is the deadline. If a child has not received first dose of rotavirus before 3 months, 3 weeks, after 4 months, you can't give rotavirus vaccine. If the child has received 1 dose, the last dose should be before 8 months. Remember these two figures. 3 months, 3 weeks is the first dose. 8 months is for the last dose. Parents bring their 3-month-old child who has received 1 dose of rotavirus vaccine at 6 weeks but have lost all the records. How to proceed? See, remember rotavirus except mono, that is RV1, Rotarix, that has 2 doses. All other rotavirus vaccine in the market are 3 doses. So first rotavirus vaccine taken, they have lost, think that it is the other brand and make sure give another 2 doses. Total should be 3. If the child has taken 1, lost the records, use any other vaccine, total make it 3. 6-week-old baby who received the first dose of rota spits out the vaccine partially. Parents are worried as it is costly. Sir, you are charging so much, baby spit it out. What to do? No need to repeat. My pranams to Sanjeev Rai sir and Venkatesh sir. MMR vaccination, how many doses? Remember 3 doses, 15 months, 9 months, 15 months and 5 years. 3 doses should be given. Just after giving MMR vaccination to a 9-month-old baby, you realize that it has been given IM. You are supposed to give subcutaneous, it has gone IM. What to do? Never, don't bother, it will work. Not the other way. Those who are to be given IM should not be given subcutaneous. Varicella vaccine for post-exposure prophylaxis, again know this, if a child is exposed to another sibling or friend, within 3 days if you give varicella vaccine to the exposed child, 90% that the risk is not there. So 90% coverage, so within 3 days if the parents bring other child that he is also not immunized and he has been exposed, you can tell the parents 10% chance are there that he might develop few lesions, definitely no complications. So within 3 days, 90% efficacy. Why varicella vaccine at 15 months, though it is licensed to be used after 12 months? Because at 12 months, studies have shown that risk of breakthrough chickenpox is more. So IAP has scheduled at 15 months. Hepatitis A vaccine, post-exposure prophylaxis. Yes, we are not giving, but literature says up to 15 days of exposure, give 1 dose of hepatitis A, it will protect. Inactivated or live, any difference, postgraduates? Which one do you choose? What is the difference? We have both inactivated hepatitis A vaccine, live hepatitis A vaccine. Inactivated is 2 doses, 0 and 6 IM, but live hepatitis A is 1 single dose and subcutaneous. Remember this, it's subcutaneous route. For catch-up vaccination after 10 years, suppose somebody says, I have not received hepatitis A, I keep eating outside, I want to take hepatitis A. The recommendation is, do antibody titers. If it is not there, give hepatitis A because it works out cheaper than hepatitis A. So you can do antibody titers in that person and then decide whether he requires or not. Again, conjugate vaccine, polysaccharide vaccine. We were using polysaccharide typhoid vaccine since probably 8-10 years till now. We were giving every 3 years 1 dose. Now conjugate vaccine is there. All of you know polysaccharide vaccine should be given after 2 years. Conjugate vaccine can be used before 2 years. We are giving pneumococcal conjugate at 6 weeks, typhoid conjugate at 9 months or 6 months itself. The reason is polysaccharide vaccine stimulates the peripheral zone of the germinal center, which is not yet developed till 2 years of age, whereas conjugate vaccine stimulates the central zone. So conjugate vaccine can be used from 6 weeks, 10 weeks, whatever. But polysaccharide, pneumococcal polysaccharide, typhoid polysaccharide, all are after 2 years. Remember this. A mother brings her 5-year-old child who has already received 2 doses of typhoid polysaccharide vaccine asking for new typhoid vaccine. She wants conjugate. Sir, you have given 2 polysaccharide, now we want to have conjugate. Yes or no? Yes, after at least 4 weeks of the last dose of polysaccharide vaccine, give 1 dose of typhoid conjugate vaccine. HPV vaccine. Now a new HPV vaccine 9-valent has come to the market. Affordable patient at 12 years, you are given 3 doses. After 2 years, now the mother comes and says, there's a new 9-valent HPV vaccine. I want to have that also. The recommendation is not to give. No need to give. 3 doses, quadrivalent you are given, that's enough. If you are starting, you start with 9-valent. 33-year-old married woman has come to your clinic asking for 9-valent quadrivalent vaccine. Again, this is a new thing. See, Gardasil, that is quadrivalent, which is available, we can use up to 45 years. Whereas this vaccine is approved till only 26 years. Remember this. If she is 33 years, as on now, we are not supposed to give. Good evening, Madam Vijaya, Madam. No. HPV for boys, yes, 9-valent is approved in India now, not the quadrivalent. Again, influenza, trivalent and quadrivalent we have. Trivalent, 2 types of A and 1B was there. In India, lots of studies showed that almost 30 to 40% of incidence was because of type B. So they introduced type B. Out of the 2 common strains are Yamagata and Victoria. So what we are having now is quadrivalent vaccine, influenza vaccine, which has 2 hepatitis A, that is H and N, H1N1, H3N2, and also Victoria and Yamagata. That is a quadrivalent vaccine. In India, we belong both to northern and southern hemisphere. Whichever vaccine is latest, we can use. No need to wait for other hemispheres. Split virion and 4 subunit vaccine, any vaccine is equally good. One more for postgraduates, I'll tell you, any influenza vaccine, starting doses at 6 months, we start with 2 doses first year, then every year 1 dose. Up to 9 years, whenever you start. Suppose the child comes at 4 years of age, they ask for influenza. First year, you have to give 2 doses with 1 month gap, and then each year 1 dose. After 9 years, it is single dose. Rabies vaccine, recent WHO recommendation for post-exposure and pre-exposure, we were giving 0, 3, 7, 14, 28. Now they are taken off 28, they say 4 doses enough. 0, 3, 7, last dose is between 14 and 28, any dose. But in India, because cases are more, they say still you better. WHO recommends only 2 doses, 0 and 7, that's all. A mother brings her 3-year-old son who had received the complete post-exposure prophylaxis 2 months back. Once again, a street dog bite today. What to do? These are all the practical situations in office practice we face. Up to 3 months of post-exposure prophylaxis. That means a child has finished 0, 3, 7, 14, 28 today. From now up to 3 months, whatever dog bite, no further vaccination. After 3 months, lifelong, if the child has received post-exposure prophylaxis completely, it is only 2 doses, 0 and 3. Remember this. So lifelong, it is only 2 doses. No need to repeat the entire dose. 18-year-old boy comes to your clinic with a street dog bite history today, but had received post-exposure prophylaxis 4 years back. As I said, he has received 4 years back. Just give 2 doses, 0 and 3. That's enough. No need to restart with 4, 5 doses, and don't give immunoglobulin because he has already received the vaccine. Some again, should we aspirate or should we not while injecting the vaccine? There is no need to aspirate because we are using the anterolateral aspect of the thigh. Blood supply vessels are very less. You can just directly inject. While injecting vaccine, when you aspirate, little blood came. The ideal and ethical situation is you have to take out, throw it away, use a fresh vaccine. The pediatrician will be losing the money. So why that headache? Don't aspirate, just inject. Expired vaccine. We have given the vaccine, father suddenly takes up the box and says, sir, already expired 2 months. What to do? You will say, nothing, don't worry, all those things. But expired vaccine, if it is inactivated, kill type toxide, you can repeat any day next, same day or next day. If it is a live vaccine, if it is expired, repeat it on the same day or give 4 weeks gap to repeat the dose of the expired vaccine. These are all very important because once we practice, once we write, if others see, they should know he is doing ethical practice. Now coming to general instructions on immunization, important for postgraduates. Vaccination at birth means as early as possible within 24 to 72 hours after birth, or at least not later than 1 week. Whenever multiple vaccinations are to be given simultaneously, they should be given in the same sitting. You can't give 2 vaccines today and 1 vaccine tomorrow. MMR, suppose I have to give MMR and chickenpox, 2 live vaccines. They have to be given the same day. You take out MMR, you search for chickenpox, it's not there. Why to lose the patient? Today I'll give MMR, you come tomorrow for chickenpox. No. Maximum same clinical sitting. That means if you are there from morning 10 to 2, 10 o'clock you give MMR, by 1 o'clock chickenpox. That is the rule. The recommended age in weeks, months, years means completed. 6 weeks means 6 weeks completed. 9 months means 9 months completed. Any dose not administered at the recommended age should be administered at a subsequent visit. If they have missed, you continue that. The use of a combination vaccine generally is preferred over separate injections, obviously for the reason that we have to give you multiple pricks. Again, any 2 live vaccines, same day or 28 days gap is a must. If given less than 4 weeks apart, the vaccine given second should be repeated. Suppose you are given MMR, by chance after 3 weeks only you have given chickenpox, repeat chickenpox after 4 weeks again. The minimum interval between 2 doses of inactivated vaccine is usually 4 weeks, except rabies. For example, you see DPT we give at 6 weeks, 10 weeks, 14 weeks, so 4 weeks gap should be there. Vaccine dose administered up to 4 days before the minimal interval of age can be counted as valid. Suppose today, 2nd of December, I have given a pentavalent vaccine to a child. They are supposed to come on 2nd of next month, January. But by chance they came on 24th or 25th of this month only. Without seeing you have also injected, that is taken as invalid. Probably up to 4 days. Second means up to 28th onwards if you have given, it's okay. Before that, it is invalid. Any number of antigens can be given on the same day. We give 3, 4 vaccines on the same day. Changing needles between drawing the vaccine into the syringe and injection is not necessary. Different vaccines should not be mixed in the same syringe unless specifically licensed and labeled for such use. If they, suppose you take Pentaxim, they give hip separately, diluent separately, you mix it. You can't take other vaccines, mix in a single syringe and give. When necessary, 2 vaccines can be given in the same limb, 1 to 2 inches apart. We do give that when we are giving pentavalent, IPV and pneumococcal. 1 limb we give, but 1 to 2 inches gap should be there between 2 vaccines. The anterolateral aspect is the preferred site. The distance should be 1 inch at least. Although most experts recommend aspiration gently, there is no data, so don't aspirate while giving in the injection. Any dose not administered at the recommended date should be administered at a subsequent visit when indicated and feasible. If they have missed out typhoid vaccine, they have come at 1.5 years, yes, it's okay, you give. There is no recommendation to wait until a vaccine reaches room temperature before administration. It should be administered as soon as possible. You have taken out from the refrigerator, you will tell the patient, oh, this is very cold, you wait for half an hour, let it become warm. No, you can rub toxides in your hand so that the cold thing is gone, you have to give immediately. 2 or more inactivated and live vaccines can be administered at any interval. Suppose I have given today Pentavac and Privinar or pneumococcal. After 5 days, if IPV is there, you can give IPV. You can, but only for live vaccines, 4 weeks gap is must. Patients should be observed for 15 to 20. This is a very serious issue. I've had 4 patients. 5 minutes they brought inside. So now I make sure sit in the vicinity for 5-10 minutes and then go, because our fate also should be good. If vaccine and immunoglobulin preparations are administered simultaneously, use separate sites. We have like hepatitis B, immunoglobulin, we give on one side, vaccine on the other side. If vaccine leaks during administration, vaccine should be repeated. This also we have had situations where needle is not tight, in urgent, little vaccine leaks, we just push off the patient. No, ideally you give the vaccine again. If it was a live vaccine, repeat the dose on the same day or 4 weeks later. If part of a dose of an oral vaccine was spit out by an infant, count the dose and do not repeat the dose. Again, rota vaccine you are giving, some children, they suck and take inside, some take 5 minutes. In a busy OPD, this baby is not drinking, patients are waiting, you are pushing, some babies they spit it out. If partially it is spit out, count the dose, no need to repeat. If a child sneezes after live attenuated intranasal vaccine, influenza vaccine, again count the dose. Expired, I have already told. Diluents vary in composition, therefore the only diluent which is assigned by the manufacturer should be used. Because the MMR is there, diluent is not there, just take sterile water, mix and give. No, it's not advisable. And ideally, all diluents also should be kept in the refrigerator between 2 and 8 degrees. Because many, even I was doing in the initial practice, anyway, it's a diluent I was keeping outside. It has to be kept inside, 5 more minutes. Or at least 24 hours before use. These are I have told already. Contraindications and precautions. There are contraindications and precautions before using a vaccine. You're going to go through the literature. These are the minimum resuscitative equipments you should have. These are the places where the vaccines should be stored. Lower down, middle one, upper storage. And please remember, no vaccine should be stored in the door. So don't, because you have ordered many vaccines, there's no place, keep it in the door also. No. This is the VVM, how to recognize whether it's usable or not usable. These are types of AEFI, adverse event following immunization. It could be a vaccine reaction, program error, it could be injection error, maybe coincidental or unknown. No. Because while Gardasil the trials were going on, there were 5 or 6 deaths in Andhra Pradesh, and they said it was because of the trial. Then everything, they had given few thousands of doses. Out of that, 1 or 2 were suicides, 1 was an accident. So probably it was coincidental. So new vaccines in the list, OPV, rotavirus, IPV, typhoid, influenza we are using. The changes I've already told you. IAP says 1 dose OPV followed by 5 IPVs. Whereas the government says 0 dose OPV, 6, 10, 14 weeks OPV, then OPVs continue. 2 doses of IPV, 6 and 14 weeks, and a booster now at 9 months. Rotavirus vaccine, I said, 2 doses. If you don't know which one, total make it 3. Typhoid, now we have conjugate vaccine. It's only 1 single dose. Though there are, again, to be 1 more dose, no dose. Ravi sir is against second dose. I said 1 more dose. Some other person said controversy is still there. But IAP guidelines clearly says as on now it is 1 dose. We don't know, few years down the line they might say it's clearly written as on now it is 1 dose. Influenza vaccine, whichever vaccine is available, use, but know the dosage schedule. 0.5 ml universal now, not no 0.25, not 0.5. Below 9 years, 2 doses at the starting age. Then every year 1 dose if they want. Above 9 years, no need of 2 doses, 1 single dose. In the pipeline, we have dengue virus, RSV, malaria, HIV, TB, and plenty are there. Probably it will take a long time. Ravi sir and myself are involved in the dengue virus vaccine trial. It's not yet started. What about myths about vaccination? Vaccines cause autism. Huge, or so many literature, media in UK, MMR caused autism. It's out now. It's not necessary to vaccinate early in age. No, earlier the age, better the protection. The vaccine schedule is too aggressive and should be spaced out. No, we want protection. Our body can take 1 million antigens. We are giving few. You have to convince the parents because the list is so long. Parents, sir, again next week, again, sir, one more. They are so frustrated, but you have to convince them. Last slide. The effectiveness of vaccines has never been proved. Infant immune system can't handle so many vaccines. Natural immunity is better than acquired. These are all the myths, what the parents think. Finally, increasing antibiotic resistance. Very few new antibiotics since many years. We are playing with the old antibiotics. Prevention is better than cure. Thank you.
Thank you, Dr. Prashant, for this comprehensive coverage.
Thank you.
Right from definitions to various vaccines and the problems faced during office practice.
Yes, sir.
Just to emphasize and re-emphasize the importance of vaccination, he has already mentioned what we have achieved, eradication of smallpox, polio. Most of us in our office practice, we do not emphasize the importance of vaccination, which is very unfortunate. It is better now with this comprehensive coverage. Most of the postgraduates should learn what are the problems we face. The recent benefits that has been mentioned is just by proper immunization, promotion of breastfeeding and nutrition, the present day under 5 mortality can be brought down by almost 2/3. What more achievements you want? And the immunization agenda of 2030 by the WHO is to no one is left behind. Because just we saw the pandemic lockdown and there is a resurgence of breakage of this vaccination process resulted in resurgence of measles, typhoid and other vaccine preventable diseases. So the floor is open for questions.
Please. Anytime. Even if it is 2 months back, dog bite, child is fine, you start immunizing.
Okay, sir. Thank you, sir.
That because if alcohol and along with the needle, if it enters, it can cause local irritation, madam. That's one of the reason.
For ages we gave nothing.
But now they say that's one of the reason. Along the needle, you are taking few alcohol particles inside. In duration, local pain increases. So saline is always safer. That's what they say. Just keep it there.
Just have a comment on that, Pushpa. The WHO recommended that you don't need to clean except with water unless the area is visibly soiled. All right? But the problem with spirit swab is especially with live vaccines. There is a possibility of the vaccine getting inactivated if the alcohol goes in along with the needle. That said, previously there was this concept, especially with the DPT vaccine, that if you do not change the needle, the vaccine tracks along the needle site and that causes more reactions. That has also been disproved now. So it is more of a possibility of inactivation of the live vaccines and the fact that it is unnecessary, because WHO recommendation of Dr. Shataram Baligan had a long WhatsApp fight about this, whether we should use alcohol swabs or not. But WHO recommendation is not to use.
That is one thing, madam. In a hurry, just
you have to wait for at least
wait
30
for
seconds
to dry.
after you use the swab.
Yes, madam. Yes, madam. If it dries up, if you just wipe and inject, these are the reason. As you say, you wipe, wait for it to dry up and then give, the chance are less. Yes, madam.
Right now, WHO recommendation is that it is unnecessary.
If there are no other questions, I'll take 5 more minutes because I think the sponsor of this PEDICON has asked me to. Yes, sir, please ask.
This government actually they are giving DPT second booster. Usually we give it 5 years, but most of the literature says maximum upper age limit for DPT.
I didn't get you, sir. Age?
DPT.
DPT?
Wholesale pertussis vaccine.
Up to 7 years.
Up to 7 years.
After 7 years, it's not recommended. But
supposed to
still
give-
between 6 and 7, still it's reactive. But up to 7, you can use DTWP.
Yeah, but majority of the schools we are getting frequently calls. We are getting vaccinated tomorrow.
I think they are giving TD, sir, now 10 years, and they are not. It's
even for 6 and 7 years. Most of the time it is first standard and second standard student mother they'll be calling. Most of the time it is first standard and second standard.
But recommendation is up to 7 years. After 7 years, you should not use.
Not
DTD.
supposed to give.
Not supposed. Correct, sir.
That is what.
We'll check.
I don't know what is happening.
TD. I have 5 more minutes. In a way, I'm lucky because I'm talking before Dr. Sivabalan, who is a wonderful speaker. I've attended many of his talks in many conferences. Shiva's room is always full. It's a fact, Shiva. So I'm lucky I'll finish before you. I'll take 5 more minutes. This is about the hexavalent vaccine. Always confusion, DTAP or DTWP. Painless, painful, painless, painful. We have to convince the parents, whichever they want, they can choose. But literature says DTWP has a margin, little margin above AP because longer protectiveness is more. But that margin is so minute that if the parents who don't want to have all the reactions, you please go ahead with DTAP. IAP approves DTAP combination vaccine, and we have hexavalent vaccine, which is instead of you give pentavalent and IPV 2 separate, 2 injections, you can take hexavalent vaccine, and I think GSK's Infantrix Hexa is there. They have proved that they are non-inferior to comparable hexavalent vaccine. The advantage about the hexavalent vaccine of GSK is it has 3 pertussoid components, the toxins or components. Again, postgraduates, can anybody tell what are the 3 pertussis components used in the vaccine? One is pertussis toxide, pertactin, and filamentous hemagglutinin. These 3 are there. Hexavalent by GSK has all the 3 components, whereas from the other company, which is Hexaxim, has only 2. Pertactin is not there. But efficacy-wise, they are doing well. And studies have shown adverse reactions with hexavalent vaccine is very less. That too, compared to Hexa of GSK and the other company, GSK is less. So whatever it is, the recommendation is give 3 DPT, whether it is DTAP or DTWP, that's a must. And immunogenicity, again, it has proven for all except, along with IPV, you can see almost it's 100%. Type 1, type 2, type 3, after 3 doses is so much. So the final thing is use pentavalent or hexavalent, but don't miss out on the vaccines. Thank you.
Thank you, sir, for your words of wisdom. We now request Dr. H.R. Hebbard, sir, to present memento to Dr. Prashant.
Dr. Sarma, who talked on liver cirrhosis is not there. Anyway, we are all, I'm alumni 93 to 96 batch. Much senior to you. We were all students of these great teachers. We remember them every day. Thank you.
We request Dr. Ashwin Kumar sir to present mementos to Dr. Shamshed Ahmed Khan and Dr. UB Shetty. Moving on to the next session, Management of Status Asthmaticus. It is a great honor and delight to welcome Dr. Anita Prabhu, Professor and Head of the Unit, Enepoya Medical College, and Dr. Ashok Kumar, Consultant Pediatrician, as dignitaries for this talk. We cordially invite Dr. Somu Sivabalan, Consultant Pediatrician and Pulmonologist at Dr. Reela Institute and Medical Center, to share his knowledge on this topic.
Good evening. Today, I am going to introduce Dr. Soma Shivabalan. This is the third time I am chairing his session, probably in KARAVALI PEDICON. So he was a postgraduate when I was working in KMC Manipal. He was doing his post-graduation in 1996 to 99. He has done his post-graduation in KMC Manipal. After that, he has done fellowship in pulmonology at Australia. Then he has joined Child Trust Hospital in Chennai, and now he has moved on to Reela Institute and Medical Center at Chennai. Now working as a consultant pediatrician and pulmonologist. He is a good orator. All of you will enjoy his talk. So now his field of interest is mainly cystic fibrosis, sleep medicine, and respiratory vaccines. And he has achieved so many awards: advanced training in pediatric pulmonology at Women's Children's Hospital at Australia, then honorary professor of IMA CGP, Tamil Nadu Medical Council Awards he has received in 2023 for his professional excellence. Then Academic Excellence Award by IMA Tamil Nadu branch. Visiting Fellowship at Royal College of Pediatrics and Child Health. Best Doctor Award by Tamil Nadu MGR Medical University. And he is editor of Scott's Pediatrics Specialties Series, Pediatric Pulmonology. He has so many other awards also. I request Shivabalan to proceed with this talk about asthma now.
Thank you, sir. Am I audible? Thank you, sir. Thank you, Chairperson. And as Ashok sir rightly said, he has become the lucky mascot for me. He is the chairperson the third time. And nothing discounting the other chairperson, you also, madam. Welcome. And today I am going to talk about the management of status asthmaticus. And they said latest in the management of status asthmaticus. As the picture shows, I was also trying to see what was the latest. Nothing much has happened in the latest. Only the understanding and the concept has changed, and the way in which we are using with confidence has changed. Otherwise, it's the same bronchospasm, same drugs, nothing new has come with regards to the latest in status asthmaticus. These are the overview which I am going to go through. And basically, what is acute asthma? Before going to status asthmaticus, it is a form of acute asthma, meaning the severe form is the status asthmaticus, and it leads on to life-threatening asthma. So it is significant paroxysmal spasmodic narrowing of the bronchial alveolar airway due to inflammation. So here again, the cornerstone is inflammation, but the treatment cornerstone mainly is bronchodilation. So inflammation, and whereas treatment we majoritarily target on your bronchodilation. So flare-up is any signs and symptoms of asthma which were not there before. Supposing a cough or a wheeze which was not there before, if it starts to appear, that is an exacerbation. Meaning if it is already there, if it is worsening, then it is an exacerbation. So from 0 to 1 if it becomes, it is exacerbation. Already 1 exists, if it becomes 2, it is again exacerbation. So always people will ask, allergia, allergia. So that has become a fashionable term. There are many things other than allergy also, and most of the time it can be an agent which causes an allergy. It can be an infection or a pollution too, sometimes poor adherence, sometimes for no reason they can have. That also we have to understand. We also will be scratching our head thinking what to answer. So the risk of flare-up is any child who has recurrent wheeze, meaning more than 3 times in its lifetime, or they say in a year's time, if they have once a anybody can wheeze once a wheezer, for all practical purpose, you are always a wheezer. If you don't expose one, then probably you are in your prolonged remission. So that we have to understand. They will say, till 30 years I had nothing, I came to Chennai and I got wheezing. It's not Chennai which gave wheezing, your tendency started to flare up for some reason. So that we have to understand. So anybody who is having recurrent episode or severe episode or uncontrolled symptoms, they are all at risk of flare-up at any time. That's why recurrent wheezers, we put them on controller. And anybody who has had life-threatening asthma, who had been in an ICU for real reason other than the VIP culture for anxiety purposes, anybody who has visited the ER for hypoxia or severe distress or any severe exacerbation in the last 1 year, meaning if you had problem in the recent past, likely to happen in the near future. That we have to understand. We cannot say you are fine now, so unlikely to get bad tomorrow. If you have had anything in the last 3 months to 1 year, likelihood you be better prepared for a worse. So if symptoms are there, better be on better control. So what is acute asthma? Practically, any patient who is not responding to initial 3 doses of your bronchodilation, for all practical purposes, asthma, the acute severe asthma. The other thing is when the parent says the child is sick, otherwise they will be saying, child paatha wheezing irukku, meaning in Tamil they say, when we look there is wheezing, where is the child playing outside, shall I bring him in? Then probably all wheezes need not be visible or audible. Audible or visible, if it is wheeze, then probably it is very sick. If the child is having noise, moving around, running around, it is predominantly, though it is significant, it is not considerable upper airway obstruction. That's why the child is able to move around or continue with its day-to-day activity. Audible or a visible wheeze, if the child is otherwise fine, you are not finding anything in auscultation, it is not asthma. That has to be very clear and straightforward. And red flag sign are any cardiorespiratory decompensation. That is called red flags. So the child is hypoxic and you cannot say the pulse oximetry is normal, so the child is not sick. The pulse oximetry is alone normal. That's it. If the child is sick, it is sick. So that also plays a role. So overall, when the cardiorespiratory things are involved, naturally your sensorium and your oxygenation to the brain also gets compensated. So severe asthma, as I said earlier, if they are not able to talk or walk or not able to eat, because among breathing and eating, breathing takes the priority, then comes your eating. So if you are significantly tachypneic or distressed, you will not be able to eat, more so in children, that we have to understand. So anybody who is not able to complete a sentence when he is otherwise normal because of respiratory problem, then take him as significant. And anybody more than 3 doses of bronchodilator not responding, take them as acute severe asthma. Anybody who is hypoxic, definitely don't ignore them. And when we say acute asthma, we always tend to say, the mother will say, much better, he is slightly better, he is a bit better. That doesn't make any sense to us. So there has to be some objectivity. For that, we need to have scores, so that when you hand over from one PG to another, that person should know how the child was and how the child is in an objective manner. So for that, there are many scores. You need not memorize on that. The respiratory rate and based on wheezing and also accessory muscles, and they are graded into mild, moderate and severe based on scores. And this you can have it as a radio reckoner either in your ER or in a consultation chamber. So there is objectivity. And whenever we say wheezing, the parents will say, I have nebulizer at home. They say wheezing means nebulizer. If you give nebulizer, wheezing will run away from their house. So that is not the real situation. So there are a lot of tall claims. Nebulizer alone will not solve the situation. Any mild attack or exacerbation, or even let it be the severe exacerbation, first line of management is bronchodilation. Either aerosol, either it is in the form of inhaled medicine, either as inhalers or as nebulizer. When does a nebulizer score over? Only in 3 situations: when the child is severely distressed, having cardiorespiratory problem, or when the child is hypoxic. Otherwise, there is no indication for a nebulization. Your inhalers will work. Never in children give inhalers directly, always with a containing chamber, that's a spacer you can use. And then the question arises whether with mask or without mask, and whichever the child is comfortable, use it. When they are in distress, even they might find it difficult to hold by the mouth and coordinate breathing through the mouth with the teeth sealed and lips pursed across. So that we have to see visibly. If they are not able to, nothing wrong in using a mask, only a bit more of dead space will be lost and the efficacy might come down a bit. But instead of not giving anything, giving it in a better way is always important. And previously they said 6 and 12 puffs. Now they say anywhere between 3 to 6 puffs is okay. Averagely we play around 4 puffs. So yeah, across age it is always 3 to 4 puffs at a single go. And it can be repeated every 20 minutes and 3 times it can be given. And now the concept of oxygen delivered nebulization or the oxygen delivered driven nebulization is there, and that is because in sick children there is a risk of arrhythmia, paradoxical hypoxia. And people might wonder, when a paradoxical hypoxia can happen with nebulizer, why not with a spacer? What happens is, proportionately the amount of dose given in the nebulization is much higher, whereas in this it is much lower. So the chance of that causing significant amount of vascular dilatation is much lower. That's why it is negligible with regards to the spacer, whereas it can be a bit significant with regards to the nebulization. So that is the scientific thing behind. Now people all talk about SMART therapy. SMART is nothing but single maintenance and reliever therapy, where it is a combination of your steroids, inhaled steroids, and also your long-acting beta agonist. The long-acting beta agonist we mean is only formoterol and not salmeterol. Though we have 2, salmeterol is not used as a SMART therapy, only formoterol containing combinations are being used. The common formoterol containing formulation is only budesonide and formoterol, which is called by different names, and this has been recommended in children more than 6 years of age. We should remember, and maximum dose of formoterol per day is only 72 micrograms, and irrespective of 100 or 200 of the steroid preparation, one actuation gives only 6 micrograms. So in a maximum in a day, you cannot go beyond 12 actuations. So over enthusiastically, like 3 puff early, 2 early, 3 early, 4 early, ultimately it can lead on to all sorts of complications, because long-acting beta agonists can cause complication and also cardiac toxicity. That we have to have it in mind. With regards to oral corticosteroid, as I said before, though we plan about bronchodilation, predominantly the problem is inflammation. So your bronchodilators don't have your anti-inflammatory action. Oral corticosteroids can be given because the idea of giving repeated dose is still the inflammatory process, anti-inflammatory process sets in. Try to maintain your airway. Whatever bronchoconstriction happen, try to widen away that gap so that the air keeps moving in. That is the idea behind. And oral corticosteroids can be used 1 to 2 milligrams. In children, they say 0.5 to 1 milligram will do. Orally, even prednisolone can be given. If the child is not vomiting, oral medicine is fair enough. Irrespective of oral or IV, it means the same. And in acute exacerbation, the role of nebulized steroid is questionable. Most of the time they said put budesonide and astellin or whatever, and that doesn't work. Though studies say initial first hour, if you give very high dose of inhaled steroids, that can avert the severity of an exacerbation, but in practical terms, that early we also see. So practically it's only parenteral steroids. Parenteral is meaning oral, or in realest of real situation, IV. IV meaning only when the child is sick or getting hospitalized or getting an IV cannula in, or if the child is vomiting continuously or refusing to take in toto, then we can give that. Otherwise, you need not. And for that action to set in, usually it will take not minutes and few hours. Till that time, you need to sustain your action with your bronchodilators. And usually parents will say, my child has grown. Should he still use a spacer? Your child might not grown, his name remains the same, so the technique might remain the same, and the efficacy of the drug instilled also remains the same. So we have to always use a holding chamber, that is your spacer. That reduces your hand-breath coordination, reduces local side effect, and improves drug delivery, though it is tangentially opposite to what people think. Use of face mask, as I said, as the situation demands. Age doesn't matter. 7 years, it doesn't mean you should not give. In COVID time, lot of seniors, when they had COVID, they were given budesonide 800 micrograms per day. I myself had seen many people finding it difficult to take it by a spacer. So even 40, 50 years, they need to be put on a mask so that the understanding was varied. The scenarios vary, and all the time with 3 puffs or 3 actuations, the children don't improve by a wheeze. So in case they worsen, or if they are hypoxic, or there is deterioration, then probably supplemental oxygen. Then this situation, the real nebulizers might hold in. And here don't worry about the dose of nebulization. With regards to salbutamol, less than 20 kg, it is 2.5 milligram. More than 20 kg, across age, it is 5 milligram. Whereas with levosalbutamol, it is half the dose of salbutamol at a higher cost. So other than that, there is nothing much. Don't get confused. mg per kg and all don't calculate with regards to nebulized medicine. And comments on oral prednisolone here again, and in case you insert a cannula, you can change it to IV. It can be either IV hydrocortisone or MPS, whichever way it suits you. And any child with inhaled medicine in the form of spacer and inhalers or with a nebulizer, they should have a sustained response. And sustained response meaning at least at the end of 4 hours, they should be able to maintain their improvement. If they are not able to sustain the response for 4 hours, then they take them as a high-risk category and you admit them, at least overnight you keep them with them. Yeah, once time they deteriorated, again you give 3 times and they improve, don't send them home. Most of the time these are worsening happens at night, and most of the time kids come at night, and night time don't take a chance if they are not able to sustain for 4 hours at least. And still not responding to 3 doses of SABA with oral steroids, or if the pulmonary score is more than 6, or if any of the red flags with regards to cardiopulmonary decompensation is there, always admit the child. Take care of ABC like the PALS tells you, and anything less than 92 or 94, you maintain oxygen with the devices available with you. And most of the time, we don't stick on to the cutoff of 92 to 94. Supposing any drop in saturation more than 3 from the personal best or the baseline, that itself is considered to be hypoxic. Don't wait for the magic number of 92 to arrive. And whenever we admit, despite the child not responding to 3 puffs, 3 times of 3 puffs and oral steroids, add on ipratropium to it. Ipratropium here again, less than 1 year is 250 micrograms, and more than 1 year is 500 micrograms. 500 is not available. We are across age, we are using only 250. And as I said before, depending on the oral intake condition, continue with your steroids. If there are no improvement, it can be a severe exacerbation. Always think about your diagnosis. Are we right in the diagnosis? Go back to your basics. Consider differential diagnosis and also think of complication. If you are sure that it's the diagnosis, see if there is anything more to it. If still it is not, then think about complication. Then the question of chest X-ray arises. When do we do X-ray? Do we routinely do X-ray for all exacerbation? Definitely not. But if it is coming for the first time, as a baseline at least we do an X-ray, though the Westerners say even for that it is not required. For the first time, never before had one do an X-ray just as a baseline, and not routinely, not each time you see for the first time. Meaning if it comes to you for the first time, who is already a visa, who has 8 X-rays, don't do it again. And if in subsequent episode, if the child is not responding or if there is poor response, to rule out complications we can. And if the child has a localized lung finding, meaning severe wheeze, the left side is more wheeze and right side is less wheeze, then better be careful. Or one side decreased air entry, better be careful. Or a tracheal shift or the cardiac shadow being shifted or pulled the other side, better be careful. So clinical conditions also gets important. And here it's, how do we, okay. Here this is a sign of air leak, and here we can see there is subcutaneous emphysema. Subcutaneous emphysema, we can feel the crepitus, and also in X-ray we can make out at times. And here it is tension pneumothorax because it is shifting the mediastinum to the other side. Then if that be so, in addition to your bronchodilation, immediately don't stop your bronchodilation. In addition to your routine management, also handle this. And there can be atelectasis also, more common in less than smaller children. Why? Because of the ill development of pores of Cones and Lambert, collateral circulation has been hampered. So smaller children tend to have more chance of atelectasis or microatelectasis, and it doesn't discount the adults too. For some reason, adults too can have. And pneumonia, if there is an overlying pneumonia, most of the time we say only the viral infection that triggers and wheeze, and that's most commonly been recommended, but nothing prevents bacterial infection also from triggering a wheeze, though in clinical sense we don't say that. And when there is pneumonia, though it is presumed to be a viral pneumonia in the background, still we treat them as bacterial when the child is otherwise sick. This is another child who has had multiple episodes of wheeze, at least 2 to 3 episodes. It's only hardly 1.5 to 2 years, 3 episodes of wheeze, 5 episodes of wheeze in the past, normal in between, parents are wheezers, and the child has had 2 normal X-rays and 2 other X-rays which showed hyperinflation on the left side as compared to the right, and the child also has 2 normal X-ray. In between the child was normal, so it was presumed that microatelectasis would have been there, or some differential air entry for differential bronchospasm was being recommended. But it was referred this time. Why? Because the child did not respond and it was worsening and there was hypoxia. So the child was referred. So because of the background, it's younger the child, it is not looking fine. So we wanted to know how the audible wheeze was there. We wanted to know how the airways are, whether an underlying airway pathology was there. When we did, there was a foreign body, right? So it was on the right side, and we are happy about that, and at least a diagnosis is made. So when we looked into the other side, there was one more foreign body on the left side. This child had absolutely both sides equal air entry, right? So this was almost like a splinting in this. So rare things do happen. It was a Christmas tree fig which the elder child while playing has put into the mouth of the younger one. The child has choked, probably it has gone unnoticed. So with regards to foreign body, we always say no history of foreign body. So the history need not be always forthcoming. So anybody across age can have a foreign body. It need not be always a witnessed episode. A normal chest X-ray does not rule out a foreign body. And madam will always say, all the madams will say, when do you do LP? Whenever you suspect meningitis. So when you suspect foreign body, you have to do a bronchoscopy, meaning CT and all the fluoroscopy and all are only surrogates. They will not rule in or rule out a foreign body. That we have to have it in mind. So diagnosis was only by high index of suspicion. The Western books will say vegetative foreign body and non-vegetative foreign body, whereas here it is expected, unexpected and suspected. Expected is obvious, green garden variety. They come saying they choke. Suspected is differential air entry and the X-ray suggestive of. Unexpected is something like this. You do for something else and find out something else. And despite your bronchodilation, steroids, your oxygen support and ipratropium, still if the child doesn't work, don't hesitate, go ahead with your magnesium sulfate. Many are reluctant in using magnesium sulfate. Easily you can use anywhere between 25 to 70 milligram, maximum of 2 grams. We usually round it up to 50 milligram per kg and round it up to 2 as a maximum. And it can be repeated once every 6 hours. We don't frequently repeat, one time we repeat. Beyond that, if there is a necessity, we see the magnesium level and then we repeat, because magnesium can cause hypotonia and hypotension. And there is a role for isotonic magnesium sulfate too, which is 150 milligram can be, those solutions are not available, only the injectable we put along with SABA, short-acting beta agonist, and then we nebulize. This is in children over 2 years of age or 5 years of age, not in a younger one we do. And SABA with isotonic magnesium sulfate results in much better bronchodilator response. So with regards to parenteral bronchodilator, overall IM epinephrine has been indicated only for anaphylaxis and angioedema in addition to standard therapy. Nowhere else it's recommended, though as a first aid when nothing else is available, this can be used. And parenteral infusions, there are a lot of controversy. We have not got there, though we see the severest of severe Vs. We have not gone with IV bronchodilation. Aminophylline we dread using, and IV terbutaline is not freely available. And overall, as a next step, as an adjuvant, high flow humidified nasal cannula for oxygenation is being used, and that scores over your non-invasive ventilation. And if the child has an impending cardiorespiratory arrest or a progressive deterioration in your oxygenation or ventilation, then as a last resort, it's ventilated, meaning intubated. Taking an intubation tube in a wheezing child is something not good, and it invites complications further, and it is used as a very last resort when nothing else is responding to. So these are the other options, let's not bother much about. On weaning, we wean it as last in is first out, meaning whichever we added to the last, then supposing HFNC we have added, then we take that out. Then of course magnesium we have taken it out, then ipratropium we take out. Ipratropium more than 24 to 48 hours we don't give, because cholinergic, anticholinergic action sets in, and that itself causes drying of secretion and fever-like situation on the warmth in the child. So we don't use beyond 24 to 48 hours, that's a recommendation too. And any child who's on a nebulized bronchodilation is being changed to inhaled bronchodilation. And if the pulmonary score is still less than 3, and if the child is able to sleep well, breathe well, eat well, and active as how the child was before the onset of this episode, and sustain this episode for 4 to 6 hours, then that is the time to go home. And when the child goes home, we should make sure they don't come back again with a similar episode. So a return action plan is also given. So as I said earlier, higher dose of inhaled corticosteroid within the first hour decreases the need of hospitalization. We are not seeing most of the kids in first hour, so don't even use that in clinical scenario. Antibiotics only when indicated when suspected of an bacterial infection and a pneumonia, otherwise no role for routine IV beta agonist. And LTRA, that's a leukotriene receptor, has no role in acute asthma. Sedatives, no role. Child cranky, crying, not keeping nebulizer, no role, because it brings down the respiratory drive and worsens things further. ABG routinely not done. NIV has its supportive role, and chest physiotherapy don't do. We will be potentiating an air leak. Routinely you don't, any pulmonary condition when we don't know what to do, they say keep tapping the child. So don't do that, it potentiates a air leak. Mucolytic expectorant in a normal child, mucolytic is not required. Give good hydration, that is the best mucolytic. Expectoration, allow the child to cough, that is the best expectoration. Cough syrup, here the cough is because of the bronchial wall irritation, so no cough syrup. PFT and spirometry, don't try to prove it is really a wheeze. The child we don't think is malingering here, so don't do that. And with regards to the return action plan, SABA or the smart therapy, SOS and review in a day's time. We cannot ape the West. Yes, they will say, give steroids, give this, give that, and see whenever you have time. So that is not happening here, because they will be overusing on your SABA, they will not be using the controller. So as an emergency, let them do that and come back to you. And steroids don't advise routinely, because after 1 year you might see a Cushing-Hart child and they'll show the prescription on your face saying, you only asked us to give. So don't do that. And steroids can be given in a highly compliant patient and high-risk patient, and not more than 1 dose. The next day they have to see you. These are tailor-made to our recommendation. And symptom chart so that you know what has happened in between, overall the progress. Symptom chart is one of the best to have an overall idea of how the disease progress. So overall, think globally and act locally, and just because the West says don't take a printout and give, and when they are uncontrolled symptoms, think about diagnosis, drugs, dose, delivery and device. All these things have to be checked. And comorbids, and we tend to ignore comorbids. Immediately we say allergic rhinitis, GERD, this, that and all. We tend to ignore obesity. Obesity is rampant. Almost every child is obese. That is a risk factor. And smoking, it's been again underpinned, and that again should not be excluded. And recent development, now there is no use for relievers alone. Relievers have to be used only with at least intermittent steroids. Why? Because exacerbations are characteristic by inflammation and airflow limitation. Airflow limitation we are handling, whereas inflammation we are not doing anything. And SABO alone will resolve the bronchospasm, but no action on your inflammation that is happening. And regular use, previously we said nothing will happen, there is no tolerance. Now people had said repeated use of bronchodilators, in the long run the response to bronchodilator itself will come down. So simultaneous anti-inflammatory and reliever use have to be used. Though the child is not on controller, during that time at least you give them inhaled bronchodilation or oral steroids is what is the recommendation. That is more so in children over 5 years of age. And SABA as a monotherapy is no longer advised. And GINA's guidelines, that's why there is no definition called mild asthma. Anybody with a recurrent wheeze, they can have and present as acute severe asthma. That's why any recurrent wheezes by all parameters require some forms of controller. Overall, any child who is on more than 3 times bronchodilator in a year warrants controller. Whether you use it for cough or whatever, for real reason if you use, then they warrant a controller medication. And nebulized versus IV, and either we can increase the dose of nebulizer solution or the frequency of your nebulization. Now it has been told any dose beyond 20 minutes or 30 minutes is not going to be of any benefit, and not more than 2.5 milligram of salbutamol is of any benefit. So that is one thing we have to remember. Overall, proper diagnosis and control of asthma to prevent acute severe exacerbation, identify risk factors and worsening. If a risk factor is available, then try to avoid one, advise on that. Otherwise, don't give a list, avoid factors, and give an action plan titrated to our situation, and judicious use of short-acting beta agonists. Also, never ignore your anti-inflammatory medications, and nebulized magnesium sulfate does have a role. IV magnesium sulfate, don't hesitate to use. And aerosol therapy with SABA is the cornerstone. Aerosol I meant is not only nebulization. MDI with spacer is equally good enough. Thank you.
Thanks, Dr. Somu Balan, for giving a brief talk on how to manage severe asthma and status asthmaticus. And we have come since my postgraduate days, 25 years ago, where we are just giving IV aminophilin and IV beta receptor. We have come a long way, as mentioned by you, in the management of acute severe asthma. And not only that, you have given us a brief this of when a child is not not responding to the usual nebulization, continuous nebulization of acute attack, we must think of other things, differentials other than asthma. Always do an X-ray and a bronchoscopy to rule out other complications of asthma like pneumothorax, and also think of foreign bodies, unrecognized foreign body by doing a bronchoscopy. Thanks a lot for enlightening us regarding all these aspects.
Thank you.
And regarding the recent developments of inhaled and other nebulized bronchodilators.
Thank you, ma'am.
Thanks.
Thank you.
Question from the audience.
Any?
The studies are saying that dexamethasone is better than hydrocortisone. What is your experience?
No experience because we are using predominantly oral steroids. And DEXA dose is 0.6 milligram. Single dose is fine. Single dose is good enough. That is the dose which is being used for group 2. And no major things. The ideal thing is recurrent use of oral steroids have to be avoided in the form of controller medication. And use some form of steroids. Some are happy with salbutamol, some are happy with levosalbutamol. It's something like that. One have an edge over other. The baseline is any of the things, know the concept and use one.
Thank you.
In view of time constraint, we regret to inform that we would not be taking any further questions.
Thank you.
We invite Dr. Nagabhushan Karan sir to present a memento to Dr. Somu Sivabalan. We request Dr. Leslie sir to hand over a token of appreciation to Dr. Anita Prabhu and Dr. Ashok Kumar. This session is adjourned until inauguration. Thank you.
Good evening, everyone. I am Dr. Shruti Bharadwaj. I am Assistant Professor, Department of Neonatology.
I am Dr. Rahul Prasad, final year postgraduate, Department of Pediatrics.
And we are going to be the host for the next 1 hour. So ladies and gentlemen, esteemed guests and distinguished speakers, a warm welcome to all of you to the KARAVALI PEDICON. The Indian Academy of Pediatrics, IAP Udupi and KARAVALI, they together form a formidable alliance dedicated to advancing pediatric practice and nurturing the future of healthcare of these young lives. KARAVALI PEDICON is a product of this, and it's a great proof of this alliance. We are gathered here today to celebrate the spirit of pediatrics and to gain valuable insights from our esteemed panel of speakers. Today, we embark on a journey of knowledge and collaboration in the field of pediatrics. Without further ado, let's dive into the exciting agenda we have for you. So please join me in welcoming the esteemed guests for today. Our chief guest is Dr. Alladi Venkatesh, Senior Pediatrician, Professor and ex-Head of the Department of Pediatrics, KMC Manipal. Our other guests of honor are
We'll call you, sir.
Dr. Sanjeev Rai B, Chief of Research, Father Muller Research Center, Mangalore, and former Dean of Father Muller Medical College. Dr. Vijaya Shenoy, Professor and ex-Head of the Department of Pediatrics, KMC Manipal, and also of KS Hegde Medical College, Mangalore. Dr. Naveen Salens, Associate Dean, Professor and Head of Palliative Medicine, and Chief of Manipal Comprehensive Cancer Center Care. Dr. Shiran Shetty, Professor and Head of Medical Gastroenterology, and Deputy Medical Superintendent, Kasturba Hospital.
I call upon Dr. Dinesh M. Nayak, Professor and Head, Department of Pediatrics, Dr. TMA Pai Hospital, Udupi. He is also the President of IAP Udupi and the Organizing Chairperson of KARAVALI PEDICON. Dr. Leslie Edward Lewis, Professor and Head, Department of Pediatrics, KMC Manipal, and Organizing Co-Chairperson of KARAVALI PEDICON. And Dr. Kausik H. Urala, Associate Professor, Department of Pediatrics, KMC Manipal, Secretary IAP Udupi, and Organizing Secretary, KARAVALI PEDICON, to escort and accompany the guests onto the stage.
Thank you all for being seated in your respective seats.
Before we proceed further, let us invoke the blessings of the Almighty Lord Krishna, as Udupi is the land of Lord Krishna. With a prayer, I invite Dr. Sandeep Kumar BK, Associate Professor, Department of Pediatrics, to lead us in the invocation.
मधुरा पुरी सदना मृदुवदना मधुसूदना इह स्वागतं कृष्णा शरणागतं कृष्णा मधुरा पुरी सदना मृदुवदना मधुसूदना इह स्वागतं कृष्णा शरणागतं कृष्णा मधुरा पुरी सदना मृदुवदना मधुसूदना इह स्वागतं कृष्णा शरणागतं कृष्णा मधुरा पुरी सदना मृदुवदना मधुसूदना इह स्वागतं कृष्णा कृष्णा मुष्टिकासूरचाणूरमल्ल मल्लविशारद मधुसूदना मुष्टिकासूरचाणूरमल्ल मल्लविशारद मधुसूदना मुष्टिकासूरचाणूरमल्ल मल्लविशारद भुवलयपीठ मर्दन कलिङ्गनर्दन गोकुलरक्षण सकल सुलक्षण देव मर्दन कलिङ्गनर्दन कल्प कल्पशतकोटि असमपराभव
वीरमुनि जन विहार मदन सुकुमार दैत्य संहार देवा
वीरमुनि जन विहार मदन सुकुमार दैत्य संहार देवा मधुर मधुर रति साहस साहस विजयवती जनमानस पूजित मधुर मधुर रति साहस साहस विजयवती जनमानस पूजित साधप गरे पगरे सदस सरिग पद साधप गरे पगरे सदस सरे रे ग पद स ग प गरे पगरे सदस सरे ग रे ग पद साधप गरे पगरे सदस गरे पगरे सदस साधप गरे पगरे सदस तकदनि कुकुल्ताना के तकदीम 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 कृष्णा
Thank you, Dr. Sandeep and Dr. Anvita, for the lovely invocation. Now, let's hear a warm welcome address from the President of IAP Udupi and the organizing chairperson of KARAVALI PEDICON, Dr. Dinesh M. Nayak.
The purpose of learning is growth, and our minds, unlike our bodies, can continue growing as we continue to live. Quote, unquote, Mortimer Adler. Learning is a universal word that can be used for various contexts in our lives, and today this word is to be rightly used to enhance our current knowledge in pediatrics, to care and serve better for the children of this society. Keeping this motto in mind, KARAVALI PEDICON 2023 has been jointly organized by IAP Udupi and Department of Pediatrics KMC Manipal. Ladies and gentlemen, a very good evening to one and all. I deem it my proud privilege to stand before you and propose the welcome address to this august gathering. First and foremost, I extend a warm welcome to the Doyen of Pediatrics, Dr. Alladi Venkatesh sir, for gracing this occasion. It's truly an honor to have you, sir, with us today. Sir has been a constant source of inspiration for all of us throughout. It's still fresh in our memories, the moments we shared with sir in the year 2017 during our inaugural KARAVALI PEDICON and Dr. Meera Baliga oration held at Kundapura. Sir is still going strong, and I think we need to emulate his qualities as far as possible. I feel truly blessed to welcome today the teacher of teachers, Dr. Sanjeev Rai, whose contribution towards pediatrics is truly laudable. Personally, I am always indebted to him for what I am today. A hearty welcome to you, sir, for having consented to be amongst us. It gives me immense pleasure to welcome our own Dr. Vijaya Shane, with whom we have a long association. Welcome, madam. We have on dais today the distinguished and young, energetic administrators of KMC Manipal and Kasturba Hospital Manipal, both Dr. Naveen Salins, Associate Dean, KMC Manipal, and Dr. Siren Shetty, Deputy Medical Superintendent, having They have truly etched their impressions in their respective fields of medicine with their extraordinary skills and academic excellence. A hearty welcome to both of you on this occasion. A cordial welcome to our own Dr. Leslie Lewis, Professor and Head of Department of Pediatrics, KMC Manipal. A smiling face, a good leader, known to provide a congenial work atmosphere for his colleagues, and a good teacher for his students. It's his willingness that paved the way for organizing today's event as a joint venture of Udupi IAP branch and Pediatrics Department of KMC Manipal. And I also take great pleasure in welcoming our Secretary of IAP Udupi branch and Associate Professor of Pediatrics, Dr. Kaushik Kurala, with whose constant support things have turned out good for this event. KMC Manipal Pediatrics Department has truly benefited from our Nari Shakti. Yes, I extend a hearty welcome to our mentors, Dr. Nalini Bhaskaranand, Dr. Vijayashane once again, and Dr. Pushpa Kini. Thank you, madams, for all the care, love, and power that you have blessed us all with. A special warm welcome to Dr. Gauri, who was instrumental in sort of reviving and conducting regular CMEs during her tenure as IAP Udupi President. A warm welcome to you, madam. We are extremely happy that many of our pediatric alumni who readily agreed to be a part of this event and contribute their expertise to this event as a key resource persons. I feel extremely happy to see many of our students here doing well in their career and are setting benchmarks in their profession. I extend a cordial welcome to each one of you for accepting our invitation and obliging to be a part of this event. I'm extremely delighted to have with us faculty from many distinguished medical colleges in and under our district, that's our neighboring Mangalore district, and also faculty from our own institutions, from various other departments, and who are involved in pediatric care. A hearty welcome for coming over and gracing this event. We look forward to your contributions as chairpersons and judges for various events lined up. The meticulous planning and execution of this KARAVALI PEDICON 2023 has been a truly rewarding one for all of us involved. The efforts of each one of you has been to make the two-day event a grand one. It is really heartening to see several members of our IAP Udupi branch at this event. A hearty welcome to all of you. My welcome address shall be incomplete without expressing a cordial welcome to all the office bearers of IAP Udupi branch and all my colleagues at Pediatrics Department of KMC Manipal for their untiring efforts and constant support to put up this event in a successful way. A hearty welcome to all of you. We also have amidst us few undergraduates, which I thought would be better to expose them to pediatrics. So we are expecting few undergraduates also for registration, and of course, all our pediatric postgraduates. A warm welcome to all of you, and may you benefit the most from various learning sessions in these 2 days. So wishing the two-day event a grand success. Once again, a warm welcome to each one of you. May you benefit and keep doing the best always. Thank you.
Thank you, Dr. Dinesh, for the wonderful welcome address, and we warmly welcome you to this event. Now, we will move on to the official inauguration of KARAVALI PEDICON. I request all the dignitaries on the stage to kindly light the lamp, symbolizing the enlightenment and progress we seek in the field of pediatrics. I also welcome Dr. Pushpa Ji Kini, Dr. Nalini Bhaskaranand, Dr. Sheila Mathai, Dr. Sudarshan Udupa, who is the organizing co-chairperson, and Dr. Karen J. Moras, Treasurer IAP Udupi, to join the ceremony.
Thank you, everyone. I request you all to get back to your seats, please. Having distinguished guests share their thoughts with us is an honor. Please join me in welcoming Dr. Sanjeev Raibi, Chief of Research, Father Muller Research Center, Mangalore, former Dean of Father Muller Medical College, to share a few thoughts on this occasion.
My teacher, Professor Alladi Venkatesh, my colleagues from stage to down, Nalini, Pushpa, Vijaya, and all others. And half of them we know right from the beginning, including Shiran, happened to be our undergraduate student. And Leslie, I mean, we are the teachers of his children. So in that way, we are related to each other. Well, it reminds me that I am also an alumni of yours, because ours was the last batch which left KMC, and probably Nalini took over as the first batch of alumni, because earlier it was all of us has to come from Mangalore to Manipal for 3 or 6 months. And I had the great privilege. Normally, the teachers welcome the students. In this case, I had a privilege of welcoming Dr. Alladi as a professor when he came here. That time, there was no other teachers. Actually, me and G.J. Bhatt was the staff, and Madam Meera Kamath was abroad, and Malati Bhatt was also not there. So it is we who welcomed him to portals of KMC Pediatrics. And ever since then, he was our guide, philosopher and all. I can share the thoughts, what he has told us, and it holds good even today. What he said is, you make some diagnosis, don't argue with any one of them. If you are right, they think that you did the right thing. If it is wrong, you think, thank God, my wrong diagnosis I did not argue out. So that was his thing. The second one is, never make over-enthusiastically make a diagnosis. He gives a narration of a Mongol child, all of us. One of his colleagues, she delivered a baby, it was a Mongol, and looked like a Mongol. Then during rounds, you're talking about when he was an ICH, child health. So there he said, it's a Mongol child and all. That was his colleagues. So she was sad. Later on, years later, he brought the child and told, this is a child, a normal child whom you said is a Mongol. So ever since he said, don't be over-enthusiastic to make diagnosis very early. Keep quiet. Over a period of time, we can come to know about it. These are the simple things what he talks. His teaching is on fundamentals. Because he says, if you know the fundamentals, the pediatrics is very easy. In pediatrics, what you should know is what is normal. Abnormal, anybody can say. Many a time, most of the things are not, looks abnormal, but actually it's a variations of normality. So these are the few things which has come. For me, I mean, particularly Dinesh, persistence made me to be here, and it's a pleasure thing. I can see all my colleagues. Moreover, the second reason why I decided to come is to see my teacher, because it's for a long time. Of course, I used to see him sometimes in Hyderabad, once or twice I had been there. Otherwise, it's very rare to see him because he's not come for most of the functions. And these doyens which has built these departments, and their footprints has made us to reach whatever we are today. And we are indebted for their whatever little ABCs of pediatrics they taught us. I once again thank Dinesh for calling me and being with you all. And nice to see you once again. And wish you a very, and this is yours is Golden Jubilee, I suppose. Yeah, recently we just finished our Diamond Jubilee of KMC Mangalore. So welcome to Ravi and all were there. So welcome to KMC for that Golden Jubilee. This is a Golden Jubilee year. Golden Jubilee. So wish you all the best. Thank you very much. Thank you.
Thank you, Dr. Sanjeev Rai, for the lovely thoughts. Now, I would request Dr. Vijaya Shenoy, Professor and former Head of the Department of Pediatrics, KMC Manipal, and former Head of KS Hegde Medical College, Mangalore, to share few words of wisdom.
Good evening, everybody. I need this, otherwise I'm not visible to the audience. Yes, thank you. Yeah. Good evening, everybody. Respected Professor Dr. Alladi Venkatesh sir, respected Dr. Sanjeev Rai sir, other dignitaries on the dais, senior members of IAP Udupi District Branch, and organizing team of KARAVALI PEDICON 2023 led by Dr. Dinesh Nayak and Leslie Lewis, colleagues and friends. I would first like to thank the organizing committee for calling me here as a guest of honor. I was a faculty in KMC Manipal from 1983 to 2004. Earlier, Udupi was, I'm sure you all know, Udupi was part of Dakshina Kannada district. And then it became Udupi district somewhere around 1997, if I'm correct. And earlier we had to join IAP Dakshina Kannada branch. But after the Udupi district was formed, we formed our own Udupi district branch. That was way back in the early 2000s. And I was the head of the department of pediatrics in KMC Manipal. And that is the time with my colleagues, Dr. Nalini, Dr. Pushpa, and Dr. Mirabaliga was also there. We had the first meeting of IAP. We formed the IAP Udupi district branch, and in a small classroom, and it was inaugurated by the legendary pediatrician, Dr. P.N. Krishnamurthy, with only 4 or 5 senior Udupi pediatricians in the audience. And there are a lot of hiccups earlier, in the early period, but later we managed to do some good work also. Actually, I remember that we had a few programs. Not only that, we had a NAS and PALS workshop in which even the local pediatricians took part. It was a big thing for them and for us. And so it's very nice and gratifying to see that what was once a small group now has become extended and full. We have a full-blown group now, and they also having a lot of activities. Especially Dinesh mentioned the Dr. Mirabaliga oration, which was in 2017, and together with that there is a CME every year. So I'm very happy, and I congratulate the past and the present members of the Udupi district branch. I'm very happy, like Dr. Sanjeev Rai said, all of us came here especially to meet Dr. Venkatesh. I'm very happy to meet Professor after many, many years. He has been my teacher. He, Dr. Mirabaliga, and in Mangalore we had Dr. Ramarao, Dr. K.R. Pai, Dr. P.N. Krishnamurthy, they're all my teachers. And whatever, I think my sentiments will echo with the crowd, whatever we have learned, whatever experience we have got, whatever skill we have got, is all because of these great teachers. So I will respectfully thank him today. Again, I did it in the morning, sir, again. And what is another very satisfying thing about this program here this year is that we have a lot of old students who are very experts in the field of whatever they are doing. We have had gastroenterologists, we have had pulmonologists, we have had heads of the departments giving all the lectures, and that is very satisfying to us because we have taught them and they have learned from us. That's like somebody said 25% from us and the rest of it from their own effort, and they are doing good for the community. So we had a wonderful morning session today about the alumni, and I really enjoyed the session. Similarly, we had a Golden Jubilee function of 60 years of MD Pediatrics in KMC, Bangalore, which was also attended by a lot of alumni. So I'm very happy that I'm here today to hear the lectures, to meet old friends, and to meet old teachers. And congratulations to the KARAVALI PEDICON of 2023 for holding this beautiful session. Thank you.
Thank you, Dr. Vijaya Shenoy, for your valuable thoughts. I invite Dr. Naveen Salins, Associate Dean, Professor and Head of Palliative Medicine and Chief of Manipal Comprehensive Cancer Care Center, for address the gathering.
Firstly, I am an adult physician in the sea, among the sea of pediatricians. I think I'm very privileged and humbled both to share the stage and the space with the most eminent of the eminent people in the stage and below. Few of them I have known as a student when they were professors or heads of the department and unit heads. So it's a very humbling experience for me to be here. And I thank Dr. Leslie for this opportunity, and Dr. Dinesh Nayak and Kaushik Kurala. I was thinking, what is that I should speak today? And when I was looking at, and the theme for 2023 International Pediatric Association was quality care for every child everywhere. And the word was quality. And the first thing that it comes to my mind is quality is equivalent to KMC Manipal Pediatric Department. I think the KMC Manipal Pediatric Department is the epitome of quality, with a legacy that was there from madams, from Nalini Madam, Vijaya Shenoy Madam, Pushpakini Madam, Srikiran Sir, quality head Munkur Sir is there here, Leslie Sir, Ramesh Sir. I think all of them have demonstrated such an epitome of quality, and I think the theme probably resonates so much with the work what the KMC Manipal is doing. And what's the best way of knowing quality is that you entrust your own family to the team here, and I think there's no other words that can resonate with quality. But another thing that also came to my mind is that the UNICEF theme for this year is that every child, every right. This is the theme for 2023. And probably in these testing times that what we are, we should probably take a time to reflect upon the rights of the children that are violated probably because of wars which are happening in Gaza or Ukraine, talking about probably something that we have to reflect upon and to do our bit in the situation that we are in. And with this small note, I would like to thank again and wish this conference the very success. Thank you.
Thank you, Dr. Naveen Salins, for your kind words. Now I invite Dr. Shiran Shetty, Professor and Head of Medical Gastroenterology and Deputy MS, Kasturba Hospital, to address the gathering.
Thank you. A very good evening to all of you. I think I'll not take more than a couple of minutes. So, respected dignitaries, Professor Venkateshan Sir, Vijaya Madam, Professor Sanjeev Rai Sir, and all the dignitaries on and off the dais. So, I would like to thank for this kind invitation, and it's a privilege to be a part of this inaugural program and also to be a part of this KARAVALI PEDICON 2023. So, firstly, I would like to congratulate the Department of Pediatrics and also the organizing secretary and the chairman and also the IAP Udupi for conducting and hosting this wonderful program. And I've been known that it's been conducted very regularly, and it's been a very much academic feast. So a couple of points. I'm a physician and a gastroenterologist, and it's close to me because my brother is a pediatrician. And also I would like to echo that Professor Sanjeev Rai was a dean when I did my internal medicine, although I didn't really learn under him, but I had learned a lot of things. Sir was a very simple human being, very humble, always approachable. When, back it was, 2004, back in 2004 and 5. And I've seen in that one of the few qualities in few of these leaders we see in our teachers, and that's make them apart. And few things, the pediatrics is a profession like any other medical profession. What's special about pediatrician? It doesn't not only treat pediatric patients, but you nurture the future generation, which is very, very important, and which is a great contribution for the society. That makes them apart. And like I think the previous speakers and a few, we know that what's difficult in children, diagnosis, because you don't have a history. So you have to completely rely on only very subtle history or findings. There might be no history. So calling or terming somebody normal, it's very difficult. As an adult physician, we have history, we have a lot of investigations, but on the other hand, pediatrician have to actually have a lot of clinical skin and observation. What I learned from pediatricians in my MD day, UG days was the observation skill what you guys have is tremendous. I think all the medical students should gain that. And the next very important quality what you guys have is patience. We don't see those things in any other medical fields, although we see, but the majority of the pediatrician, the quality of patience is something amazing, and hats off to you. And once again, I would like to thank the organizing secretary and IAP Udupi for this wonderful program. Have a very good evening. Thank you.
Thank you, Dr. Shirin Shetty, for your encouraging words. Now, as a tradition of KARAVALI PEDICON, we recognize the work of senior pediatricians in this area and felicitate them, and IAP Udupi takes honor in doing this every year. This year, we are felicitating 2 exemplary senior pediatricians for their invaluable contributions to the field of pediatrics. I request Dr. Vijaya Shenoy to please come to the center of the stage for felicitation, and I invite Dr. Srikiran Hebar to introduce Dr. Vijaya Shenoy, Professor and former Head of the Department of Pediatrics, KMC Manipal and KSHEMA.
Dignitaries on the dais, my colleagues, students, friends. Dr. Vijaya Shenoy doesn't need introduction because she is so well known in the field of pediatrics, but still some of us who have entered the world of pediatrics recently may not be knowing about Madam. I know any amount of words or vocabulary would not do justification to explain the great virtues and qualities of Madam, but formally it is my privilege today to introduce Vijaya Madam. Dr. Vijaya Shenoy was born in the year 1954, completed medical graduation from KMC Mangalore in the year 1976. Then she did her post-graduation in pediatrics in 1981. In 1983, she joined as teaching faculty in Department of Pediatrics, KMC Manipal. Later, she became professor in year 1991, and then she headed the Department of Pediatrics, KMC Manipal from the year 1999 to 2004. And after that, she joined to KSHEMA, Mangalore, and she became the head of the Department of Pediatrics in KSHEMA, Mangalore. She also did her pediatrics endocrinology training from the Lawson Wilkins Pediatrics Endocrine Society, North America. Madam had been a professor par excellence, a great teacher. I was lucky to work initially under Dr. Pushpakini Madam, then under Dr. Nalini Madam, and then after Dr. Vijaya Shenoy Madam. I think I am the only one who has worked under all the three, and I have been lucky to imbibe great qualities from all of them. So I worked under Nali Madam and Pushpakini Madam, and then when joined Vijay Madam's unit. So I thought by now I have mastered most of the things. So Madam's approach was very different. She is very, as morning Dr. Pushpakini Madam explained, she was a very thorough clinician and an accommodation. So whenever she will come and I just give the brief history, and she would ask one or two things, only those two I wouldn't have asked the patient. So that way I learned lots of things from Madam. Another two things I want to share at this moment. Madam used to keep telling always, the busy person is the one who has time for everything. And I add, including some time to waste also. So Madam never would expect if something is not done. If I say I was busy, then Madam would say, you know, the busy person is one who knows, who has time for everything. That is her motto. And she always maintained very neat discipline when she played the role of whether as an undergraduate teacher, whether as a postgraduate teacher, or whether as an ardent clinician in the bedside, or as an investigator for a research work, or as a guide for the thesis, or moderating seminar, or even Madam was president for IAP Udupi for 1 or 2 years before she left KMC Manipal. So, and also as a colleague, as a friend with her family. So she maintained the same discipline which she maintains in approaching to a child with illness and treating in all aspects of her profession. That was the greatness of Madam. And Madam always used to, sometimes I used to get surprised. Night postgraduate would tell, Vijay Madam just called and asked to start on something or asked to send some investigation. Then next day I asked, Madam, how did you in the night suddenly? No, Karen, when you have a difficulty in approaching a case, you have to simply sit and just keep thinking about that case for some time, and suddenly something will flash to your mind. That will really help. I have used this, and many times it has helped in diagnosing many difficult cases. So I can go on sharing so many good things and the virtues of Madam, which is really helpful for whether as a colleague or whether for a student, for a patient and parents, for every aspect of life. Madam also, without any ego, actually when I was president Udupi IAP, I had asked Vijay Madam once to come as for felicitation, but that time Madam could not come. Today morning when she saw me, first thing she said, Srikaran, sorry, when you had called, I had not come. Then I said, Madam, I don't have any grouse against that. That's her greatness, humility, and always greatness lies in humility. So with this brief introduction, I am so happy to present great personality, great teacher, Dr. Vijay Shani, to this August gathering. Thank you.
Thank you, Dr. Heba, for the lovely introduction. May I please request all the dignitaries on the dais to join for the felicitation of Dr. Vijaya B. Shenoy.
Thank you all. I humbly request Dr. Jaya Gauri to come on to position and occupy the distinguished chair for felicitation. I invite Dr. Leslie Lewis to introduce Dr. Jaya Gauri, Senior Consulting Pediatrician, Udupi.
Popularly known as Dr. Gauri, Dr. Jaya Gauri Hadigal is a well-known pediatrician as well as Rotarian from Manipal. After completion of her MD DCH from Kasturba Medical College, Manipal, in 1985, she was trained in United Kingdom for 7 years in pediatrics and neonatology. She returned back to India and has been practicing as a consultant pediatrician and neonatologist at Sonia Clinic and Nursing Home, a women and children's hospital at Manipal. Born on 23rd April 1956 to illustrious parents, Dr. Gauri is well known for her kindness, resourcefulness, and accomplishments. Her father, Dr. A. Krishna Rao, was the Dean of Kasturba Medical College, Manipal, and her mother, Dr. A. Padma Rao, was a doyen in obstetrics and gynecology. Dr. Gauri was married to late Dr. Vishweshwar Rao, a gastroenterologist, and blessed with 2 sons, Rotarian Sushil Hadigal, an engineer residing in Norway, and younger son, Dr. Sanjay Hadigal, a pharmacologist based in Bengaluru. Both her daughter-in-law are engineers employed in multinational companies, and she has 3 grandsons. A staunch Rotarian from 2002, she has just completed her stint as District Governor of District 3182 in the year 2022-23. She is the first woman to occupy this honor in the District 3182 and 3181, comprising of 8 revenue districts. She is a major donor level 2 and a Paul Harris Society member and an End Polio Fellow. As a Rotarian, she has worked for Pulse Polio and learning disabilities. Her district project was early detection of learning disorder, where she trained more than 2,000 teachers to detect children with learning disorders. She is a past president of IAP Udupi District, and during her tenure, a lot of activities has taken place during her president's period. She was also president of a child welfare committee of Udupi District. A multilinguistic, Dr. Gauri, she enjoys movies, books, lives a passionate and spirited life, being a mentor and a friend and friend to all. So with this brief introduction, kindly join me in welcoming and honoring Dr. Jaya Gauri Hadigal.
May I please request that all the dignitaries on the dais
dignitaries on the dais and my dear friends, you cannot believe how much this means to me today. I haven't the faintest idea why I am being honored. I am not a part of KMC. I have done private practice for the last 50 years. So when you're born and brought up in such a place, it's natural that people get to know you and you do some good work. I don't have any claims to any academic distinction. What really makes a difference to me today is that I'm being honored in front of my professor, Alladi Venkatesh. Nothing can mean more greater to me than that. Sir, you have been the source of inspiration to me all through my tenure as a pediatrician taught me lots of things. As somebody just spoke about how he said, I remember one day when we were in the outpatient department, there was a child who was lying on the bed in one of the rooms, and he said, you all don't seem to find anything wrong with that child's hands lying down so still. Something, when we kept giving the history, you remember in the olden times we said no lymph nodes, no this thing, no that thing, no that thing, a long list of things. And he said, you all keep telling me all the unnecessary things, but why is this child sitting so quietly like that? And these are the small things that I keep remembering all through. That when you look at a child, you must look at the small things that really matter and not go and worry to make a big diagnosis. I don't know why Leslie chose me to be honored today. I think he just likes me a little bit. That's all. Okay, I have been the president of the best IAP district. Okay, that's president of IAP district. Best president. Vijay Shana is making it better and better. And I'm also very, very honored that I am being honored along with Vijaya Shanai. She has accomplished so much in her profession, whereas I am not. I don't think I have like that in academically, but I've done my bit in the profession and in my society and community, which I'm happy about with God's help. Thank you so much. Sir, thank you for being there here today with us. That is the best. He is always shy to come front and then do.
Thank you, everyone. We are now privileged to have with us a luminary in the field of pediatrics, our chief guest, Dr. Alladi Venkatesh, and I'm extremely proud to introduce him. Dr. Alladi Venkatesh joined KMC Manipal in 1976 when Dr. Meera Baliga was already on academic leave. His tenure at Kasturba Medical College was from 1976 to 1991. Just the next year after joining, he started the MD and DCH Pediatrics program and established a world-class academic department within the next few years. Several postgraduates have been trained under him since then, and they are extremely successful and present worldwide. He has also conducted many conferences and academic CMEs during his tenure, including the first National Neonatology Forum Conference, that is the first NeoCon, which was held here. The first NALS, which was called then, also now called as Neonatal Resuscitation Program, was held during this conference, when the trainers from United States, like Dr. Vidyasagar and team, trained many budding neonatologists and pediatricians at that time. As we can see in this picture, there are a lot of distinguished pediatricians and neonatologists. Some of the big names who got trained at that time are Dr. V.K. Paul, Dr. Meherban Singh, Dr. Ashok Diorari, Dr. Sudarshan Kumari, Dr. Sunit Singhi, Dr. Sheshivani, Dr. Bhaskar Raju, and many more. Currently, he is retired and he stays in Bangalore. His wife was also the head of the Department of Radiology at Kasturba Medical College. He has 3 lovely daughters who are extremely successful, and one of them is a professor of neurology at NIMHANS, Bangalore. He is not only a great clinician and disciplinarian, but also an excellent mentor and role model. Even now, after retirement, he has continued to pursue his academic interests and actively takes part in academic meetings and keeps himself updated. And he is undoubtedly a role model to all of us. So I kindly request now Dr. Alladi Venkatesh to share a few words of wisdom with all of us.
Can they hear me? Dignitaries of the dais, office bearers of the Udupi, IAP branch of Udupi district, and other friends. It's a great privilege PEDICON of KARAVALI branch. The shortest inaugural speech I heard was by a distinguished Australian professor. He said, I am asked to inaugurate this conference. I have gone through the program. Topics have been chosen with great deliberation. And the experts also have been chosen who fit in the best to give those lectures. I inaugurate the conference. Now it is between you and the speakers. And he said that's all the inaugural program that day. But I am not like that. I am a teacher. I don't know why he said that. I like to hear my own voice once in a way. So I don't want to let go of my opportunity to say a few words. If I am exceeding my time, please ring the bell. This is the place where I grew. My happiest professional life was spent in Manipal. I see here the 3 madams, Dr. Nalini, Dr. Pushpa and Dr. Vijaya. And I see also my Dr. Divakar, who has been my colleague here in Kasturba Medical College all through I was here. Dr. Vijaya's husband I'm talking about, not the other pediatrician Divakar. It gives me great pleasure to be here. I grew here professionally. It made me ready for the rest of my life. I am now 92. I retired at 60. Therefore, for 32 years after I left here, I was busy, excepting during COVID time, when my students made me a rule not to allow me inside the hospital. They said, this old man will come, but we can't take the risk of his getting COVID. Please, they told the watchman there not to allow me to get down from my car. That is the sort of affection I got from my students. And my wife came as a reader in radio diagnosis. She grew here, and it was the first department which had all the 3 modalities of imaging: conventional radiology, ultrasound, CT scan, nuclear medicine, and she headed the department here at a very young age. And from here, she went on to Nizam's Institute of Hyderabad, and she became the dean there. My 3 daughters grew up here. They all succeeded to some extent. And I always said, good pediatricians, unless they are married to other specialists, always have daughters. If they are married to other specialists, then the luck changes. But if a good pediatrician is there, the definition of a good pediatrician is the father of daughters. I am very lucky, and Dr. Padma Rao, the professor of obstetrics, told me one day, I can identify the father of 3 daughters. That's what she told me. I asked her, tell me why. I don't know, but I can definitely identify if a fellow has 3 daughters, I know what he is. That is the sort of luck I had with my daughters. Now we are practicing now coming back to the subject of pediatrics. We are practicing in very exciting time. Newer methods of diagnosis, newer drugs, everything new is coming into play, and newer methods of investigation. The imaging has completely changed. Neuroimaging has completely changed. The CT scan, the MRI, the PET scans have totally changed our idea of the limitations of clinical medicine. Has been proved beyond doubt. But I still feel there is a great place for clinical medicine. You should not diagnose by looking at images or investigations. You suspect a disease and then you investigate, and not come to a diagnosis by looking at the investigations. Now it looks as though physical examination has become redundant. The cardiologist, at least in our presence, does not tell us these findings. I always insisted upon the cardiologist writing down the physical findings of what he has found. But they always write what they found in the 2D echo. And they auscultate, they get better day by day because they immediately do the 2D echo, they auscultate, they compare what they found, and they improve. But whereas we just see the 2D echo reports and we don't grow. This is what I found with cardiology. Because what we heard, what our teachers have told us, Alexander Nadas in his textbook says, grey hair does not make the best cardiologist, he said. Time and again, the younger people who have better hearing are the people who can diagnose, who will hear better. Therefore, don't underrate the importance of age in diagnosing of auscultatory findings in cardiology. Newer and newer diseases. We were afraid of HIV. We thought we saw a very major disease is a problem. And now we find COVID completely devastating children in the second wave. And the pediatricians have played a very, very significant role. And still, dengue was not there when we were students. It was not there in 1990 till we were here also. We did not have dengue. And suddenly it started, and it doesn't seem to abate. It's going on. H1N1, chikungunya, these diseases have become endemic now, and they're causing enormous morbidity to children. And drugs have come, agreed, but still we are not able to say that. Now they say the vaccine against dengue will be coming, and how far, how costly it will be, how much availability it is there is still to be known. Another thing I find is the domain of pediatricians is slowly coming down. General pediatricians. Now the role of specialists is increasing. People don't come to us. If there is a cardiac problem, they go to a cardiologist. If somebody says there is a neurological problem, they go to the neurologist. And slowly our practice is getting limited to infectious disease. I agree, it's a very, very exciting part of our profession. But I still feel we should have a healthy relationship with the super specialists. I did not like the idea of the word called super specialists. They are subspecialists. In Mangalore University, myself and other senior physician surgeons stalled the starting of the super specialty course. I said you should not call super specialty, it is a subspecialty. And for 1 year, all the seniors ganged up and sent back the proposal to the Board of Studies to call it subspecialty. 1 year passed, the Board of Studies again met, and they said the Indian Council calls it super specialty, and you cannot but agree to call it super specialty. And the various professors of super specialty came and asked me, sir, at least this time you don't stop. We are starting the courses of DM and MCH courses, and please don't come in our way. We have to define our relationship with the specialists. When I found that the so-called, we see a lot of epilepsy in our day-to-day practice. And neurologists also see, and I wanted a dialogue to be established between the pediatricians and neurologists. So I consulted, there are 3 neurologists in my house. And with the help of their friends, we started the Pediatric Epilepsy Society. And then there we trained pediatricians to look at EEGs, conducted workshops. And the professor of neurology, one professor said, if pediatricians can look at ECGs, why is that they cannot look at EEGs? What is so difficult about it? This is also a graph, that is also a graph. If you the only thing is it number of pages are more, but therefore you please see that pediatricians have at least a basic knowledge of reading an EEG. You know, you not be experts. And that stuck to my mind, and I started the Pediatric Society, and I called eminent neurologists to teach studying EEGs to pediatricians. I succeeded to a certain extent, and I found that we must earn the respect of the specialists, the general pediatricians. Nobody should ever think that we are referring a case to a specialist out of ignorance. We are referring the case because we know that it's a problem. We want to be sure that the problem is correctly diagnosed, and that is the reason why we send the case to the specialist, and not because we don't know what we are doing. And my advice to young pediatricians is choose your specialists properly. Let it be any subject, gastroenterology, neurology, cardiology, so that he will share what he thinks about the case with you. That is very, very important for us to know. When we refer a case, we should know what he is going to say and what we are going to understand the process of the disease. This sort of a link must be established every time we refer a case, and neither we should be afraid of referring a case, of losing the case, nor the specialist should retain the case. This is what is, I found, once you find a refer to a neurologist specialist, they keep the case themselves who don't know what is happening. Some of them do refer back, but many of them don't. Therefore, we must choose the specialists very carefully who share our doubts and who will share his doubts with us. I find that it's not very difficult to earn the respect of the specialist. Now I find eminent nephrologists, gastroenterologists, cardiologists in Hyderabad listen to me when I say something. I'm not saying out of any great pride, but I am saying that I have something to offer. In any child I see, we as pediatricians have something more to offer than the specialist. He may be good in this field, but we know the whole child, we know the family. This is what I want to impress upon you. Time has come for us to earn the respect of the specialists. The other day, I heard somebody, the predecessor speaker, saying about rights of children. The first chairperson of the National Commission for Rights of Children, I heard her talking in Nimhans. She said there are two cities now. One city of flyovers, malls, advanced theaters, and another city, slums, 100 meters, 200 meters away. And there is enormous amount of mental health problems for children in those slums. COVID has devastated those children. The adults also are very much affected. The men have no jobs, they have no vocation, they are dying by the age of 40 or 50. The females, the women in the slums are seeking multiple partners and are seeking young men, young boys to be their partners in sex. And she said, who is to be blamed for this? And she made a very impassioned speech in Nimhans about the need for awareness on the part of general physicians about the mental health problems that are occurring now in this country, thanks to COVID and thanks to many other social conditions. So I request all of the pediatricians to also be aware of not only what's happening in our clinics, in our towns. We are all, most of us belong to middle class or upper middle class. We see those patients, but there is also another dimension which we as citizens of this country must see, must be aware, and try to do something about it. And finally, before this end, we used to complain about watching TV. Now it is a smartphone. Now we are not able to control the use of smartphone by children. We used to complain about their watching TV for multiple hours. We are not able to convince them. But now we have failed much more miserably. And thanks to, again, COVID, it is abused. And time has come for us, the pediatricians, to take measures to stop or at least reduce and control the use of smartphones, playing games and other things for children. We must find places for them to play, and there is a great need for creating places for play. That is what is lacking now. Previously, no school was allowed to be started without a playground. Now, any building you take, it's not in South Canara and Udupi district. They think it's slightly different. But in all other places, any building, a school is started. And private coaching is going on. And there is no place for playing at all during study hours. The number of suicides in Kota, we are seeing, totally unavoidable. And therefore, we should all pay attention to the social factors which are affecting children and their health, their mental health, and we should also be ready to meet that challenge. With these words, I want to stop here. Great pleasure inaugurating 2023 KARAVALI PEDICON. Thank you very much.
Thank you, Dr. Venkatesh, for your golden guiding words for the youngsters and reiterating that history and physical examination is the gold standard for diagnosis and nothing can beat it. We are really humbled and proud to have you here.
Expressing a gratitude for this enriching gathering, I invite Dr. Kaushik Churala, the Organizing Secretary of KARAVALI PEDICON, to deliver the vote of thanks.
Good evening, one and all. I know it is bit late, so I won't take much time. But it's indeed my pleasure and I'm honored to extend vote of thanks in the inaugural ceremony of third edition of KARAVALI PEDICON, that is KARAVALI PEDICON 2023. IIP Udupi is proud to organize KARAVALI PEDICON 2023, this time in Mahe campus, International Educational Hub and Shikshana Kashi. Being part of both IIP and Mahe, it's my collective responsibility to thank everyone who has contributed to the success of this conference. First and foremost, I would like to thank Dr. Ramdas Mpai, Chancellor Mahe, Dr. Ranjan Arpai, Chairman MEMG, Dr. H.S. Ballal, Dr. Lieutenant General MD Venkatesh, Vice Chancellor Mahe, Dr. P. Giridhar Kini, Registrar Mahe, for the support in conducting this conference in Mahe campus. I would like to convey heartfelt thanks to the chief guest of the program, Professor Dr. Alladi Venkatesh. Thank you, sir. I would request Leslie sir to hand over the memento as our token of appreciation and gratitude to Alladi Venkatesh sir. I would extend my heartfelt thanks to our guests of honor of today's inaugural function, Professor Dr. Sanjeev Rai sir, Professor Dr. Vijaya Shanai, Professor Naveen Salins, and Professor Shirin Shetty for gracing the occasion. I request Leslie sir and Dinesh sir to hand over the mementos to the guests of honor. Our Pro Vice Chancellor, Health Science, Professor Dr. Sharath, Dean Dr. Padmaraj Hegde, Medical Superintendent of Kasturba Hospital, Dr. Avinash Shetty, were supposed to be part of the organizing inaugural ceremony, gracing this occasion. However, because of their other official commitment, they could not attend this conference. In their absence, I would like to acknowledge their help in organizing this event, and a heartfelt thanks to all the three officials of Mahe and Kasturba Hospital. The speciality of today's or this year's KARAVALI PEDICON is all the speakers are the eminent alumnus, proud alumnus of KMC Manipal Department of Pediatrics. They have traveled all the way from USA, Qatar, and different parts of India with the just affection of the department and respect to the teachers of theirs. So thank you all the speakers for being with us and sharing your valuable experience with the august audience. I would also like to thank the seniors, chairpersons, and the judges for the paper and poster competition, which is going to happen tomorrow for postgraduates, for sparing their time and joining hands with IIP Udupi and Department of Pediatrics. Thanks to you all. Coming to IIP, I would like to extend our thanks to the office bearers of Karnataka IIP, that is Dr. Sharan Gowda Patil, Dr. Rohit Bhandarkar from Gulbarga, and EB member of our region, Dr. Sumita Naik, for all their help throughout the year. Thanks to the man behind the show, President IIP Udupi branch, organizing chairperson, Dr. Dinesh M. Naik, for making this event so organized, structured through his conceptualization and execution. Thank you, sir. Thanks to my fellow office bearer, Treasurer Dr. Karen J. Moras, for her unwavering support throughout the year in day-to-day activity of the branch, as well as in organizing the conference. Thank you, madam. So I would like to thank organizing co-chairperson, Dr. Sudarshan Udupa, all senior teachers of our branch, senior members of IIP Udupi, for entrusting in us and encouraging us to organize event of this sort. Without your help, cooperation, and encouragement, I don't think we would have successful in organizing this event. Thank you, IIP Udupi, in one word. Next is our department. Department of Pediatrics, KMC Manipal, is always been an integral and inseparable part of IIP Udupi in all its endeavors. Special thanks to pillar of our department, none other than Leslie sir, who is a true inspiration and a support system for all of us in all our endeavors. Whenever I go or we go to him with some petty request, he never disappoints us. He always pats our back, pushes us forward to do better and more. Thank you, sir. Words are not enough to express our gratitude to you. This conference would not have been possible without support, timely suggestions, advice and guidance from our senior teachers. I would like to extend heartfelt thanks from IIP Udupi to Dr. Pushpa Madam, Srikiran sir, Sunil sir, Ramesh sir, Jayashri Madam for all their valuable suggestions and advice. Special thanks to all my colleagues at department for being part of organizing committee and taking the responsibilities assigned to them very meticulously and systematically and executing it very nicely, flawlessly. The conference would not have been so well or better without all your cooperation. I would like to thank all my colleagues at Department of Pediatrics, my dear postgraduates, interns, for helping us in organizing this event. I will fail if I don't thank our office staff, Mrs. Lolakshi, Akshaya and Gauri Akka for their secretarial help. Thanks to Dr. Shruti and Dr. Rahul for being MC of the program. Thanks to Dr. Sandeep and his team for the invocation. So we acknowledge and thank pharmaceutical companies for their academic grants. In one word, I would like to thank all those who have supported us, like Ad Syndicate, Chef on Wheels, Mr. S.P. Nayak, AV team of Mahe, Dean's Office, KMC Manipal, staff of Dr. TMAPI Auditorium, Hombelaku for the cooperation. I know I might have missed few names in this vote of thanks. Forgive me. In one word, I would like to extend heartfelt thanks from IIP Udupi and Department of Pediatrics for those who have directly and indirectly helped us in organizing this event. Thank you one and all. Jai Hind, Jai IIP.
With that, we conclude the formal segment of Karavali Pedicon. We look forward to meeting you all at the banquet tonight at Sharda International Hotel starting at 7:30 p.m. A vehicle has been arranged to take those who need transport, and it will start from NIH hostel at 7:30 p.m. and return to NIH at 9:30 p.m. and then at 10 p.m. Thank you for being a part of this incredible event, and let the festival continue.
Thank you.